Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is the third Sunday of the month, January 2020. Thus, it is time for our regularly scheduled IC support group meeting. Whoops, hopefully the sound is good. Let me just check a setting here real quick. Yes. Yes, yes, yes. All right, my friends. All right, my friends. Hello, Molly. Hello, Heather. Beth. All right. All right. All right. All right. Oh, you guys, I am so freaking excited. This is like the perfect way to start 2020. It's the perfect way of starting 2020. And I have so much news to share for you. It is going to blow your freaking minds. Good, exciting news. Really, really happy, good news, okay, about IC. So, hello, Barbara. Hi, Tara. Hi, Deborah. Hi, Lindsay. Hi, Kathy. Hi, Shirley. Hi, Karine from Belgium. So I know it's a big football game. Football games today. And I wasn't sure if people were going to come. I'm going to tell you what I have been doing now for the last 10 days. Uh, for the last 10 days, I have been reading this. People, called Breaking Through Chronic Pelvic Pain, a holistic approach for relief. I'm telling you right now, this is the best book ever written. The best book ever written on IC. I can't sell it. It's on Amazon. I'm not getting paid for this in any way, shape, or form. Every single one of you, I promise you, $9 on Amazon on Kindle. You need to go get this book right away. It is going to blow your freaking mind. And it has blown my mind. And I am back in college right now. I know how I learned. This is not a casual book. If you look at this book and the way that I am working through this book, okay, look at all the yellow, right? I am studying like I've never studied before. And I'm so excited. I'm so freaking excited about the whole thing. I might swear and I'm trying not to. Okay. So let me just introduce myself first. Okay. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the national IC support group leader. I'm basically kind of the international IC support group leader now too, because I'm the only one that's doing these live. I bring to you 3 college degrees. I've got a degree in chemistry, a degree in pharmacology, drug development, master's degree in psychology. I could not get my PhD because of my own pain. My IC network, our website, was my PhD doctoral dissertation. Great irony, right? Rated #1 in the world by Harvard Medical School for the most accurate, reliable information on IC. So, and that's for 25 years. If you've never seen me before, if you've never heard of me before, icnetwork.org, please go on over there right now. Go on over there right now, learn about it, read about it. This is changing everything. Everything. Okay. So my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can ever mess with you again. No one can tell you that this is all in your head. Nobody can minimize you. Nobody can demean you. Nobody can tell you that this is your fault. Because guess what? It's not your fault. And this book explains why. So let me give you a little bit of context first, okay? Like, I'm so excited right now. My adrenaline is going crazy. So here's what we know about IC, right? We know a one treatment fits all approach doesn't work, right? Elmiron didn't work for the vast majority of people who took it. We know that IC patients present in very, very different ways. And let me just fix my computer here. You guys, if I'm looking up, I'm looking at Facebook. If I'm looking down, I'm looking at YouTube. We are simulcasting right now. So we know that IC patients present many, many different ways. For some of you, IC begins in childhood. For others, IC begins after menopause. For some of you, IC begins after having a baby. For a lot of you, IC begins after a fall. For some of you, IC begins after chemotherapy. While for others, we have no clue why IC begins. It appears one day, right? But if there's one thing we know, you're not the same. You're not the same. There is tremendous diversity in the IC population. Tremendous diversity. So, what researchers have been doing now for the last 10 years is trying to understand those diversities, right? Because we cannot have it's on Facebook right now, Deborah. Um, if there's one thing that we absolutely have to accept is that, again, one treatment does not work. Period. End of story. Why? Because there's tremendous diversity in this patient group. So, in Europe, they use 16 variations of IC. And they when they examine a patient, they really look very deeply to try to figure out what the right treatment is for that right patient. In Canada, they use 6 variants. In the United States, we do not have an agreed upon system. We use 5 variants of IC. This was proposed by Dr. Christopher Payne, who ran the IC research program at Stanford University for 25 years, federally funded IC researcher, actually chaired IC meetings for the National Institutes of Health. About 5 years ago, he came out with something called subtypes. And he did it in a very, very provocative way. He said, listen, we need to treat IC patients like cancer patients. And of course, my answer is, oh my God, why would you even bring up cancer and scare people? There's no connection between IC and cancer. He's like, you're right. There's no connection between IC and cancer. However, when somebody receives a diagnosis of cancer, it is very, very specific. You're not just told you've got cancer and you walk away. You're told you've got cancer of the left breast. It is estrogen dependent, type 1, 2, 3. Like for me, a couple years ago, complex endometrial hyperplasia with atypia and a vague architectural complex, also known as early uterine cancer. And when you're given a specific diagnosis, what happens? You are then given a more intuitive treatment pathway. If somebody just says you have IC, you don't know what the hell to do next, right? Not only do you not know what to do next, your doctor doesn't know what to do next. But if a doctor says you've got Hunner's lesions, okay, we know what to do with Hunner's lesions. And so, how do we create an intuitive treatment pathway with specificity? And one of the things that Dr. Payne railed about in his proposal, which you can actually find on our website, I have a whole section on subtyping now, because we've been doing this for 5 years, guys. If you don't know about subtyping, you're way out of the loop. He said how unfair it is that we tell patients IC is an incurable bladder disease, when for some of you it's not, and when for some of you it's curable. And he says that in his proposal, and he says that in this book. He says that in this book. So in the Payne subtyping system, we have 5 core variants of IC. Okay, variant number 1, Hunner's lesions. And I've talked about this many times in our live meetings, and you can read about those on our website, and we've got videos on it. So I'm gonna fly through this because I want to get to the important part here. So subtype number 1, Hunner's lesions. These are the patients with big bleeding wounds on their bladder. Okay. Subtype number 2, bladder wall driven. So these are the patients who have a legitimate bladder wall problem. We know your bladder wall is driving your symptoms to the great degree. If you've got pain as your bladder fills with urine that is relieved by urination. Okay. So in the bladder wall subtype, we're going to look at chemical irritation from chemotherapy. We're going to look at estrogen atrophy, which is going to make the bladder more vulnerable. We're going to look at chronic infection, chronic fungal infection as an example, et cetera, et cetera. IC subtype 3, pelvic floor driven. These are the patients whose symptoms began with some sort of muscle injury, falls, car accidents, having a baby. Okay. And for these patients, even though your bladder is screaming at you, it is your muscles that are driving your symptoms. So their pain, muscle pain is duller, it's achier, it has a burning quality. Bladder wall pain is very sharp and shrill. Somebody with a direct bladder wall injury or Hunner's lesion, the fuller your bladder gets, the worse you feel. It can be agony. Patients describe it as razor blades, ground glass, right? Whereas pelvic floor pain tends to be duller, more consistent, and absolutely has a burning quality to it. But the number one symptom that we're going to look at for somebody with pelvic floor muscle dysfunction is difficulty starting their urine stream. If you go to the bathroom, whether you're sitting or standing, and you cannot let your urine out, that means that your muscles are tight. Muscles are supposed to be long and loose and pliant. They're not supposed to be tight. Okay. The fourth subtype is a nerve injury, pudendal neuralgia. So these are the patients whose symptoms are being driven by some sort of neurological nerve driven function, usually some sort of compressed nerve. That means a nerve can be entrapped by bone, it can be entrapped by a tight, flat muscle, and your symptoms are very positional in nature. You're fine when you stand, but when you sit down it hurts, or when you bend over it hurts, or when you squat it hurts. You might even have areas of numbness. You might feel numbness on your inner thighs, on your butt, or tremendous skin sensitivity in an area. Okay, that's also a sign that a nerve is involved. And you guys, just so you know, I'm not looking at your comments at all because I'm just trying to get through this. I'm trying to get through this first. Okay, so subtype 4, pudendal neuralgia. Subtype number 5 is central sensitization. Now, in central sensitization, what happens is either because of genetics or because some sort of injury, our whole nervous system has changed and has become much more reactive. So somebody with central sensitization has sensitive skin. We have drug sensitivity. We have food sensitivity. We have chemical sensitivity. We have a wicked sense of smell. You name it, we've got it. And that's about changes in the action potential of the nerves and the nerve fibers. And basically, somebody with a normal bladder, you could put 1,000 cc's of water in, and they could walk around for hours and they don't feel it. Somebody with central sensitization, you put 100 cc's of fluid in our bladder, and we feel it. We absolutely feel it. And that's a difference. Our bladders are exactly the same. I'm in this group. My bladder is completely normal. You look at my bladder, it is a baby bladder. It is perfect. And yet, why do I have to pee when I get to a certain point, about 200 cc's for me or wherever? And that is because my nerves are different. I have central sensitization that I have inherited. Okay. But, let me ask you the question. Which subtype do you think is the biggest? Which subtype do you think has the most patients? Hundreds lesions? We know no. I'm going to say that right now. Only 5 to 10% of patients have lesions. Is it subtype 2, bladder wall driven? Is it subtype 3, pelvic floor? Is it subtype 4, pudendal neuralgia? Which subtype do you think is the biggest? Any clues? Now, what have I said in my meetings? I've said, in my opinion, the biggest group by far is the muscle injury patient. This book not only supports that, but takes it one step further and says, actually, for many of us, it's a nerve injury. It's a nerve injury for some of us. So I want you all to take your shoes off. Right now, I want you to take your shoes off and take your socks off. I just want you to do it. We're going to come back to it. You're going to be examining your feet. It's going to blow your freaking mind. Okay? Now, before we get there, again, when you get this book, you're going to study like you've never studied before. I read it once. I came back, and in my book of books, I've rewritten everything that's important. And the great gift of being older is that you want to learn, right? You want to learn. And so you're not studying for somebody else. You're studying because you want to figure things out. You're studying because you want to understand why you're in pain. And you've got to really make a commitment to understanding your pelvis. So let's look at this as a completely different way. IC is considered a chronic pelvic pain syndrome. Chronic prostatitis is considered a chronic pelvic pain syndrome, right? So let's talk about the pelvis for a moment. So we know your pelvis goes from your hip bone to your hip bone, and off of your spine, you've got your normal ligaments, your lumbar ligaments, and then you've got an area of fused vertebrae called the sacrum, right? And in your pelvis, so your pelvis is basically kind of this shape. And one of the things that I've kind of learned from reading this book is when people say pelvic floor muscles, there's an implication that the muscles are fairly flat and running along the bottom. And he explains that the pelvic floor muscles are actually a three-sided bowl. It's kind of facing this way forward. You've got muscles along the bottom, which are your levators, and then you've got muscles along the side, which are your piriformis and I think your obturators, right? Okay. And now let's think about the purpose of the pelvis. The pelvis is the anchor of the human body. The pelvis carries the weight of your upper body and transfers the weight to your feet, to your legs and your feet, right? So it has a critical role in buffering trauma, right? And so if, for example, you're lifting something really heavy or you get staggered, or maybe even you're in a car accident, you've got, and let's just say you're lifting something. Oh no, you know what? A better example is straining. Let's say you're straining. Say you're straining either to lift something or to pee or to poop, whatever. Not only are you straining whatever muscles are being used to lift, or if you're pushing with your feet, but there is a ripple effect. There is a clear ripple effect that anything that happens from the waist up negatively to your muscles or your bones are going to affect your pelvis. Just like anything that happens in your legs are going to affect your pelvis. Why? Because you've got leg muscles that come all the way up into the pelvic cavity. You've got back muscles that go all the way down, the psoas muscles, into the pelvic cavity. So the pelvic cavity and the pelvis is a very dynamic organ. It's much more dynamic. I mean, this has really opened my eyes about the consequences of injury. And so, when we think about those patients whose symptoms began after falling on your tailbone or after riding a bicycle for a long period of time or having a baby, or maybe you separate your shoulder, or maybe you break your jaw. If you break your jaw, your pelvis is going to feel it. It is actually going to feel it. If you break your foot, your pelvis is going to feel it. Think about it. So we think of downward forces, but let's think about upward forces for a moment. So when you walk, what happens? You put your weight on your foot, and then your foot has a very dynamic motion, and that weight then comes up through your legs into your pelvis. Now, so what would happen if you have one leg shorter than the other? If you've got one leg shorter than the other, either from an injury or a broken bone, or maybe you were born with it, think about how your feet compensate for that. So if you've got one leg shorter than the other, so normally your feet are like this, they're even, right? You're walking like this. But if you've got one shorter, this foot is going to arch down and this, okay, and then this one's going to flatten to try to create a level walking surface. Does that I mean, it's interesting. It's really, really interesting. How does the human body react to a short leg? We know that your feet change. Your short leg arches down and your long leg flattens, and that is not normal. And of course, there's a ripple effect up your legs into your pelvis. And we know that when your legs are when your legs are too long, one hip is going to be higher than the other, right? And so as your hips work, all the muscles that connect it are also being affected, and they're not normal. They're not being normal. So, Dr. Jerome Weiss has written this absolute love letter to his chronic pelvic pain patients, where he explains in depth how leg injuries, foot injuries, pelvic floor muscle injuries will trigger bladder symptoms. And let me just see now, seriously, have you taken your shoes off yet? Have you taken your socks off? Okay. God, it's just so many things I want to say. It's like I'm so excited. I'm so excited. I'm just stunned. I'm just stunned by what I've read. So hold on, let me go to the foot chapter for a moment. Okay. So you know what? Just bear with me a little bit. I'm going to get to it. Okay. It's. I'm going to write a huge new section of our website. I want to show you a couple of pictures, and I'm going to read you a case study. Then we're going to get to your feet. Okay. I want you to look at this for a moment. This is the bony anatomy of your pelvic cavity, right? These are your hip bones. In yellow is your sacrum. Your sacrum is critical. Your sacrum carries the bulk of the weight of the human body. It is the buffer, right? And then in pink are all the ligaments that support this. So if you have a leg that is shorter than the other, what's going to happen is that the ligament on one side rather than the other, one side's going to get shortened and one side is going to get contracted. Let's look at this for a moment. I promise you, this is going to mean something. So let's look at this for a moment. Let's look at your feet. When you walk, the force of the impact goes up your leg and right into your pelvic floor, right? Right up into your sacrum, right into these ligaments, and of course the nerves that are embedded there. Okay. How do I want to do this? Ooh, I'm excited. Okay. Let's see. I'm going to read a case report. Let me read one of his case reports in here. Okay? Case number 2. A 65-year-old woman came to see me with a history of recurrent urinary frequency and urethral pain without infection. Examinations revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual therapy to which she responded to positively. However, she continued to have pain flares. While my treatments were effective in the short term, the results only endured for variable periods. I continued to administer periodic therapy for nearly 10 years. At the time of her last visit, armed with new knowledge about the feet, I looked at her feet and noted unusually high arches. When I asked her if she had experienced any of the potential side effects of such an apparent abnormality, she came out with bilateral Achilles tendonitis, knee surgery, and more recently hip pain when waking or rising from a crouching position. In my mind, I visualized a straight line of mechanical stresses. It began with a foot imbalance, which affected her Achilles tendons, then the knees, then the hips, and ultimately the pelvic floor. A visit to the podiatrist was the last stop on her healing journey. It is unlikely that she will require any more pelvic floor sessions with me. 10 years ago, when I first saw this patient, the feet seemed too distant from the pelvis to be considered in the treatment plan. Experience has taught me otherwise. Let me give you another case study. 42-year-old man with voiding difficulty reported that at the age of 14, he had severely fractured his left foot, leaving him with a short leg. Since that time, he had assumed many abnormal positions when sitting to protect the leg. Hello, that's me. Within a year or so of this injury, the voiding difficulty began, and he was too embarrassed to mention the problem to his parents till another year had passed. He was subsequently found to have tightness of the pelvic floor muscles, which is typical of voiding problems, and had limited success with manual therapy and biofeedback. When I examined him, the short leg was apparent, as well as externally rotated legs and severe overpronation of the feet. A visit to the podiatrist proved to be the missing link, and he was cured. Here's another one, vaginal and vulvar pain. 31-year-old woman came to me complaining of vaginal pain during intercourse. The symptom was completely alleviated with manual therapy for all the tight pelvic floor muscles and trigger points of her internal hip rotators. However, the patient then began to notice vulvar pain when she exercised, which I surmised had been there all along, but was masked by the predominating vaginal discomfort. Not infrequently, localized pain responses present themselves in order of magnitude. Only when the initial discomfort clears will the patient become aware of subsidiary distress. Ongoing diagnosis is required. Okay, when I re examined this woman, I found nothing in the vicinity of her pelvis that could explain her vulvar discomfort. However, this time I scrutinized the lower extremities for clues to her new symptoms and noted extremely high arches, a sign of supination, which were no doubt the cause of her previously noted hip rotator trigger points. I referred her to the podiatrist who fitted her with orthotics, and her vulvar pain disappeared. This was one of the cases that led me to realize the importance of a routine biomechanical assessment at the time of the intake exam. Now, what do I always say? If you have long-term recurring muscle tension, muscle dysfunction, we have to take a step back and look at the bony structures. So I've always looked at the hips. I never looked at the feet. Did you ever correlate anything with the feet with pelvic pain and bladder symptoms? I never did. And then, then, have you ever heard of Morton's toe? Now, in my life, I have been diagnosed with Morton's neuroma. I have been diagnosed with plantar fasciitis. I have been diagnosed with shin splints, and I have been diagnosed, I had steroid shots in my feet, right? For years, which we always thought was the result of my professional tennis, which I did for a couple of years. So, what is Morton's toe? In 1935, Dr. Dudley Morton at Yale Medical School wrote in his book, The Human Foot, that an inherited abnormality in the first toe bone could be the reason for most foot problems, as well as painful problems throughout the body. Doctor noted if your first metatarsal bone is short as compared to the second metatarsal bone, or has too much motion in it, the bone cannot function properly to stabilize the foot, which then creates an instability throughout the body, especially in the pelvis. So, let's think about it for a moment. So here's the way the human body is built. The biggest bones are meant to hold the greatest weight. So your biggest bones in your human body are your hip bones, right? Because they're hold the weight of your trunk. The biggest bones in your foot are your big toe. Those bones. Libby, I know you say nerve injury. Just hold on, hon. You got to hold on. Okay. So the biggest bones in the human foot are your big toe. And normally, when you look at the length of your toes, the biggest toe is the longest, and they go in order. And the biggest toe, when you walk, is supposed to carry 2/3 of the weight, and your second toe is supposed to carry 1/2 of the weight. However, some people inherit an abnormality. Mind blowing, right? Where actually the bone in your big toe is too short. And when it's too short, guess what? When you walk, your weight doesn't go on your big toe. Your weight goes on your second toe, which screws up everything in your legs and everything in your pelvis. And this goes back decades. Decades. So Morton's toe means that your foot simply cannot walk normally. And it's completely curable with $2. Stunning. Now, I will tell you the person who wrote the definitive book on Morton's toe is actually a doctor named Janet Travell, who happened to be John F. Kennedy's doctor when he was in the White House. So let's look at it this way. This is an exaggerated case of Morton's toe. So you look, the big toe is shorter than the middle toe. And then the other thing you notice with Morton's toe is there's something called webbing between the second and third toe where there's more skin. So it's like the toes are kind of webbed together. But the important point here is this bone right here. You will notice that this bone of this first toe is short. It's short. It's supposed to be longer than this bone. It's shorter than this bone. And because it's shorter than this bone, when you walk, this bone is the first to hit the ground. Somebody says, can you please, hon, I can't fix notebook volume. If the Facebook volume isn't good, come on over to YouTube, okay? Okay. So, I want you to look at your toes right now. Look at them. So the first thing I want you to look at is so there are a couple of signs. Number one, is your big toe shorter than your second toe? Now, the second thing I want to look at is, do you have any hammer toes? Hammer toes is when a toe, instead of being straight, starts to curve down. I have a slight hammer toe of my second toe. And I don't know if I can show this. Okay. Okay, so I don't know if you can see this or not, but can you, if I bend this down, can you see how this toe is slightly bent down? That's a sign of Morton's toe. That means that this toe is trying to grip the surface when I'm walking. Okay, now I want you to bend your toes down like this, and I want you to look at them. And actually look at the knuckle that pops up. Look at, so you got a knuckle here, and you got a knuckle here. And I don't know if you can see this on mine, but this knuckle is about a half an inch shorter than this knuckle. That is Morton's toe. Jean, please hold on. Jean, please hold on, guys. Hold on. Remember, we have subtyping. Not everybody has this. But in Dr. Weiss's practice, with the worst chronic pelvic pain patients in the Western United States, 80% of his patients with severe IC and chronic pelvic pain have Morton's toe. It's crazy. There has to be a reason why. There has to be a reason why there is long-term chronic distress and stress of the pelvic floor in the pelvis. Shirley says, my left leg is 3/4 inch shorter than my right leg, just like your grandmother. So Shirley, there is no way for your pelvis to be normal in that circumstance. You have to have a lift in your foot to get it level so they're working normally. Teresa says, broke my leg last August, spent 2 months in a boot. My pelvic floor flared. It is undeniable now that when you walk, your pelvis is affected. If you're walking abnormally, and let me give you, I'm going to show you a picture. Where is it? So here's the bony picture of Morton's toe. And so you can see this knuckle is shorter than this knuckle. And that is exactly what I have on both sides. Okay. Where is this picture? I want to show you this picture. Where is it? Where is it? Where is it? Where is it? Okay, here we go. So I want you to look at this. I want you to look at this picture. Okay, so look, here's a normal foot. And you can see the normal foot is directly underneath the pelvis and the pelvic floor is normal. Now here is a foot with Morton's toe. So when you have Morton's toe, you cannot walk normally. So what happens is your ankle bone goes inward. And then look at the ripple effect. So your foot, your leg angles outwards. And you can see up here that this bone, your femur bone, ends up pushing far more outwards, which then pulls the ligaments. And this right here is the piriformis muscle. And the piriformis muscle is the most dominant muscle behind patients with chronic pelvic pain injuries. So, as he said in his case studies, he can get people better with pelvic floor massage, but the question is, why do the symptoms keep coming back over and over and over again? And the answer is a bony abnormality. It's a bony abnormality. And now the piece that pushed him to the point where he could fix more patients is when, in addition to doing the pelvic floor work, if that didn't fix them and cure them, and when they came back in pain, he started first with the toes, with the feet. We want to try to understand what's going on with the feet and if that's creating long-term stress on the pelvis. 80% of the worst patients on the West Coast, just like many of you in this chat right now, and many of you are going to watch this video, 80% of them have a foot dysfunction, a foot dysfunction. And it was only until he brought a podiatrist into his clinical group and got their feet fixed that their pelvic floor and their bladder symptoms completely resolved. Completely resolved. Let me give you another. I'm going to give you another one. Okay. A 50-year-old man has been seeing me occasionally for over 10 years for intermittent perineal pain. And you guys know the perineum is between the rectum and the scrotum for a man, and between the rectum and the vagina for a woman. So a 50-year-old man had been seeing me occasionally over a 10-year period for intermittent perineal pain. I'd been treating his tight pelvic floor muscles and trigger points with internal manual therapy, and though he received great relief from these treatments, pain flares inevitably occurred. Frankly, I'd never completely understood the mechanics of his symptom flares until he came in one day complaining of hip pain while walking over hiking trails. This led me to question him further and ultimately put us on the right track. I asked if there were any other musculoskeletal problems that he had not thought of to mention previously. He responded that he had always had pain at the base of his large toes, which he attributed to arthritis. But because he knew that other family members had the same issue, he never sought attention for this, quote, congenital issue. I then examined his feet, something I'm not accustomed to doing, and found bunions and moderate overpronation. The light went on. I had found the origin of his hip pain that he experienced during hiking and also during the intermittent perineal flare. A podiatrist treatment eliminated his painful flares completely. As Dr. Valmasi mentioned above, bunions are a sign of abnormal pronation, which lessens the shock absorbing action of the feet and placed additional stress on the leg and hip. This additional stress affects the hip rotator muscles. This dysfunction of the muscles can create a wide range of pelvic floor complaints, including perineal pain, and of course, we know frequency urgency pressure pain. So the question is what do you do about Morton's toe? It's fixable. Let me go get my shoes. Hold on, because I've already fixed it for me. Hold on. And I'm already better. Like, holy crap. Hold on. Okay. So these are my beloved Hokas, right? This is a shoe I wear every single day because I've always had foot problems ever since my 20s. Never connected anything. Like, what? So Hokas are known for having a just really, really thick cushioning. And since I have Morton's neuroma, for which I've had steroid shots and for which doctors have said, Jill, you worked out so much that you burned off the fat pads of your feet, which we now know is probably not correct. It's probably this Morton's toe. Okay. So what you do for $2, you make a little pad and put it under the toe so that the toe touches the ground first. This has been around. The guy created his first pad for this and got a trademark for or a patent for it like 70 years ago. And to this day, this is still the right treatment. Now, I made mine a little bit small. It's actually supposed to be bigger, right? And it goes right underneath the joint. Here, hold on. So I went to Walgreens yesterday. Hold on. I got a whole bunch of stuff. I got a whole bunch of stuff to demo to you guys for you guys today. Okay, so what you do, and I'm going to want you to Google this so you can verify it. Don't just do it because I'm telling you to do it. I want you to look at your feet, read about Morton's toe. Okay, Catherine says my toes are. Catherine, it's okay. Don't worry about that. Don't worry about that. I will explain that. Okay, don't worry about that. Remember, we have subtyping. I'm not talking about every single patient here. I'm just talking about a subset of patients here. And this is not possible. This is proven now in many, many studies. I didn't know about it. And if you get the book, it will explain it to you. Okay, and it's not a lift in your shoe or anything like that, guys. So basically, when you've got Morton's toe, you get one of these foam inserts from, what's the name of the company? Well, you know what I mean. These little flat Shoals foam inserts. And you can either do a little rectangular piece or you can do a little circular piece the size of a quarter, and you tape it to the bottom of your foot or on an insole. It's stunning. Stunning, 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 stunning. Now, again, we have subtyping. This is completely irrelevant to somebody who has Hunner's lesions. This is completely irrelevant to somebody who has chemo-induced cystitis or somebody who's got estrogen atrophy or genitourinary syndrome, or it's completely irrelevant for somebody with chronic UTI. But for a lot of us, it is totally relevant. It is totally relevant here. If you have chronic pelvic floor muscle tension like I do, there has to be a reason why. And it all goes back to bony structures. There's either something wrong with your sacrum, SI dysfunction, and if there is, we have to again look at why would the sacrum be stressed to the point that it's stressed and dysfunctional. And ultimately, in the end, everything goes to the initial source of impact. The initial source of impact when you walk that carries your weight is your feet. If your feet are incapable of distributing your weight properly and you arch one foot slightly, right? And you're not walking normally, and if it's that side that is then has more tenderness, how many of you complain of pain on one side? A lot of you pain on one side. Okay, so if you have pigeon toes, that's not normal. If you've got the opposite, which I think they call ostrich feet, where your feet go out, that also is not normal. That is also not normal, and that is a sign that your feet are potentially contributing to your pelvic floor muscle dysfunction. Yvonne says, I have an injury to your right hip. That makes this relevant for you. The $2 fix is explained in the book, and it's as simple as putting a little tiny pad underneath that big toe joint that will then allow that toe to, for the first time, probably in your entire freaking life, carry the weight appropriately. It's fascinating. Listen, I have been a support group leader for 27 years. 27 years. And this is the things that we learned over the 27 years. Number one, back 27, 25 years ago, everybody said that IC was a bladder disease. And yet, if that was the case, why didn't Elmiron help most people? I always knew. We always knew in my support group that probably 60 to 70% of the people never responded to any bladder therapy. Okay, so what the hell is that all about? And then we had the lovely Rhonda Cotterinos. Rhonda Cotterinos, the first physical therapist in the United States who went to an IC meeting at the National Institutes of Health, I think around 2008. And she went, hey guys, guess what? If you allow me to work on that patient's pelvic floor muscles, I think I can make them better. And the doctors, all the national top doctors around the world laughed at her and said, no freaking way. Even though if you go back to the 1800s and the early 1900s, every doctor writing papers about IC talked about very tight pelvic floor muscles. So you have a muscle expert coming in and threatening the status quo. And she goes, wait, have you ever considered muscle therapy? This was 20 years ago. They're like, baloney, wouldn't help a thing. And ultimately, that's really the problem with Western medicine. Western medicine compartmentalizes it. They focus on structures. And that is the flaw in pelvic pain because the pelvis is very dynamic. The pelvic floor is not only muscles, it's nerves, it's bones, it's communication from the top down, it's communication from the bottom up. You just can't look at the bladder as the potential source of this pain. We have to look at structures outside of the bladder in this dynamic, crazy universe of the pelvic to try to figure out why pain and discomfort and frequency and urgency is happening. And yes, 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 I know that people are saying, but if it's frequency, urgency, it can only be from the bladder. It's not true. In this book, he names the muscles. He goes so far as to name the muscle that will trigger frequency urgency if that muscle is damaged. We've never had a book do this before. So, hold on. So again, this is the first time I'm talking about it. Man, I have been studying for 10 days because I want to be able to say this right to you because that's my job, right? I read everything I can read. And I knew about Dr. Weiss. I've sent patients to Dr. Weiss for years. And he just retired. And it's like I'm reading this book going, oh, please, God, can I go see him? Can he please help me understand why my SI is messed up? And I'm reading this book and the light bulb is turning on. And it's like, oh, holy hell. Oh, my God. Wait, wait, wait. It's so interesting. So hold on a sec. Okay, let me explain it to you a different way. Let's look at it in a slightly different way. Okay, the name of the book is Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Okay. And he gives you an anatomy lesson like you've never had before. Like the anatomy lesson in this is amazing. Pelvic floor injury and weakness puts extra stress on the low back, hips, legs, and feet, or the back and jaw, sending muscles into fat, yada, yada, yada. Okay, so let's talk about a tail for a moment. So let's talk about a tail. Dogs and cats have tails. Let's talk about a happy dog. A happy dog is wagging his tail, right? Happy, 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 happy. And when that dog is threatened or worried, what happens to that tail? Bam, right between the legs. And it's the pelvic floor muscles that are bringing and drawing that the tail, the coccyx, in between the legs. Okay, we have a tail. It's our tailbone. And when we are up to 5 weeks in utero, at week 5 or week 6, our tail is reabsorbed and becomes our tailbone, our coccyx. but we humans have the same musculature that a dog has. Okay? Now, the other thing, okay, so again, think about a dog under stress. What do? They pull inward, they pull their tailbone, their tail in between their legs. Okay. That is, I will give you everything, Rebecca, don't worry. So that is a sign of distress. Now, the other thing to remember about the pelvis is it's really the center of the fight or flight response, right? If you are frightened, if you are scared, it is your pelvis that carries the burden of that work. Because when you're stressed, you've got the saber-toothed tiger coming your way. What happens is blood flow is pushed from the center into your legs and muscles so that you can fight or fly, and you're prepared, to run. So what do? You tuck things under, like you're ready to run, right? You're not happy. You're not wagging your tail happily when a saber-toothed tiger is running. You stopped and you're ready. You're tucked. You are ready to fight. What if you're under extreme stress over and over and over again? What happens? You tuck your tail. You tuck your pelvic floor. And what does that do? That creates unhealthy musculature. The longer you strain the muscle, the more trigger points are going to develop. And when trigger points develop, you get knots. And when you get knots, the knots push on blood vessels and nerves. The same is true with the foot. If you're walking abnormally, then you are creating total imbalance in your pelvis, total imbalance. And muscles are getting tweaked. Your pelvic floor might be turning in when it's not supposed to be turning in. It's amazing the ripple effect. And one of the things, remember in previous support group meetings, we talk about the people who are the most prone to pelvic problems. And these are people with a history of athletics, gymnastics, ice skating, where you have repeated falls, playing football. But other sources of pelvic injuries are falls. If you fall on your tailbone, if you fall on your left hip, if you fall on your right foot, if you sprain your ankle, you break your ankle, and you're not walking normally for 6 months, or as some people have said here, even after you break your leg, that leg actually ends up a bit shorter. And then, of course, now we've got this imbalance again. So I know I'm kind of all over the place with this. Let me just go through my notes here. This is important. Okay, so the way this happens is for some people when you sustain muscle trauma. So think about it this way. Your legs are imbalanced, you're tweaking your muscles. You have no idea you're tweaking your muscles, but what's happening is trigger points are developing. And you have no clue that they're latent trigger points. They're not active trigger points. They might be along the top of your hip. They might be on your piriformis muscle. They might be anywhere in there. And then finally, something happens, the straw that breaks the camel's back, and bam, 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 everything starts screaming. All those trigger points get turned on, right? And this is the progression. You have no symptoms, and then your symptoms start intermittently, and then they become constant. And so what he says is as the disease continues, you go from none to intermittent to constant. But as healing happens, you go from constant to intermittent to no symptoms. And for those of us who have healed, right, because I'm way better than I was 20 years ago, I definitely went from constant pain to occasional pain to much less pain, now very few bladder symptoms, but I'm living with muscle issues every single day. In fact, I have a new chair. if you can see my new chair. Okay. The other thing that he talks about, he has a whole chapter on trigger points, hyperirritable spots within skeletal muscle bands. The degree, let's see, they're created by excessive tension on muscle fibers from habitual straining, tightening, and trauma. The degree depends upon the muscle health. The previously strained muscle will be more susceptible. And so, what can make you more vulnerable to trigger points in your pelvis is a skeletal imbalance. Hello, feet. Number two, scoliosis. Hello, I have scoliosis. Number three, lumbar disc damage, feet, hip, or SI joint dysfunction. Also, interestingly, low thyroid, estrogen, iron, deficiencies in vitamin B, vitamin C will also influence muscle health. To treat, you must find the trigger points and, more importantly, what led to their development. Again, a musculoskeletal abnormality. Again, we have to start at the feet. So what else is a sign? What else gives us a clue that somebody has abnormal pelvic floor muscles? Number one, habitual straining. Do you strain to pee or do you strain to poop all the time? I was working with a lady, oh gosh, last week, who, I kid you not, had been straining to pee her entire life. And he's got stories about that. It's amazing. Some of the patient stories about that. There was one of his patient stories in the book was a man who I think by the time he was in his 50s had chronic urinary symptoms and chronic pelvic pain. And so he went in, he does his evaluation, looks at the pelvic floor. The pelvic floor is massively, massively tight. And it turned out that when he was a young boy, his mother forced him to have a bowel movement every morning. And if he didn't have a bowel movement, she gave him an enema every morning before he went to school. Now, can you imagine the pelvic floor tension that would have created for his entire life? And the treatment for this man was to finally get those muscles relaxed because he was tortured by his mother. Another example he gives is a gymnast is a ballerina. And it's interesting because when I went to UC San Francisco for my referral for chronic pelvic pain, my doctor, Dr. Staller, said, do you do ballet? And I went, yeah, I did some ballet. He goes, well, we see this in ballet. Okay, now we know why. Because in ballet, one of the examples that they give to young ballerinas is to pretend that you're holding a quarter in between your butt cheeks. And now you walk that way, right? And so instead of walking normal, right, where you've got a little bit of arch in your back, a ballerina tucks under, right? And so you're always walking tucked under that way. And by the time, and listen, when you're young and doing it, you're probably not going to feel it because your muscles and your bones and everything are very responsive. You don't really start to see the wear and tear of these until you're in your 20s and 30s and 40s, when we see a lot of cumulative damage to the tissues and to the muscles. Okay. Here's something else that's really, really interesting here. He believes actually that, and this is my interpretation of what he's written. Again, when I asked you, what do you think is the most dominant subtype? Bladder wall, pelvic floor, pudendal neuralgia. He really puts the bladder wall almost last. He goes pelvic floor and then pudendal neuralgia. He believes that pudendal neuralgia is much, much more common in the IC chronic pain community, because when you have repetitive trauma, you're not only damaging muscles, so you're damaging muscles, right? Oh, and so like we're like, okay, so you fall, let's say you fall on your tailbone and you fall directly on your levator ani muscle. Let's just say you fall flat, like you fall like a gymnast who's on the balance beam falls and jams her crotch right up into her crotch. Or if you're a bike rider and the bike seat is pushing right up in there. Um, um, so the question is, what's the injury? Well, the injury number one is that you've damaged and weakened the pelvic floor. At that weak spot, trigger points develop. Trigger points, we know, are tight nodules of tissue. So, what happens then with a trigger point? And I've got pictures. When you have trigger points, that muscle, instead of being long and loose, the muscle flattens. Now you've got a long, flat muscle. Actually, it's not long, it's a shorter, flatter muscle. And because you have a shorter, flatter muscle, it is now going to start impinging on nerves, specifically the pudendal nerve. The pictures in this book, again, the book that I'm talking about, the book that every single one of you, you have to get this book and you have to study this book. Okay, I am not. I've got a new book that we're supposed to be releasing on the IC network. I'm probably not going to release it, or I'm going to wait. This book is the bomb. It is so freaking good. It is stunningly good. It explains so much more than any other book about how muscles trigger the bladder, how the bladder triggers a muscle. There's, you know, that that. So another really interesting piece is at the spinal cord, right? So we know, for example, that all the nerves in the pelvis merge at one spot in the spinal cord. And so these are the nerves for the pelvic muscles. These are the nerves for the bladder. These are the nerves, the afferent nerves. You've got nerves that go up and nerves that go down. You've got nerves from the brain that go on down to communicate to the organs. And then you've got nerves that go on up, which are the sensory nerves, which tell your brain what's going on. And we already know that we have something called neural crosstalk. We know that if that nerve group is damaged, the other structures supported by that nerve are also potentially going to be compromised. So, for example, if you injure a muscle and that muscle is screaming and it is screaming up to your spinal cord, help me, help me, help me, help me. It happens to be right next to some of the nerves that control other things like organs and the vulva and things like that. And that's one of the reasons why they think that um, uh, muscles can trigger organ pain. And we also know that organs can trigger muscle pain. So we know, for example, if you're going through chemotherapy and your bladder is screaming because it's being chemically burned, it's screaming up to the spinal cord and up to the brain, help me, help me, help me, it hurts. And your spinal cord will immediately tell your pelvic floor muscles to tighten in a guarding reflex. And so organ pain can cause muscle dysfunction. So remember, what do I say? We're in the chicken versus the egg dilemma. Which comes first, the chicken or the egg? Which comes first, the bladder or the pelvic floor? Now it's like the chicken and the egg, and I don't know what else. So now we have to consider the nerves too. For some of you, it starts with a bladder injury, like from chemo. And because your bladder's screaming, your muscles get tight. And we might fix your bladder, but if your muscles are still screaming and you haven't done anything else about fixing those tight muscles, you're screwed. We've got to work on those muscles. And then for others, your symptoms begin after having a baby or a fall, where your muscles are damaged. Your muscles are damaged. They develop trigger points. Trigger points then cut off blood flow. They compress nerves. And then those are screaming up to your spinal cord, which can then affect your bladder. That's why you can't just consider the bladder. And that's the key point. That's the key point right now is we cannot just look at the bladder when we're trying to figure out what IC is. Monica, you'll have to start at the beginning. I can't go back and do it. What I'm telling you is that this book is written by one of the best pelvic pain experts in the world named Dr. Jerome Weiss. He just retired and he has made kind of an astonishing breakthrough in understanding how muscles can influence and damage the bladder and trigger all the symptoms that we associate with the bladder: frequency, urgency, pressure, pain. And it might not be the bladder at all, it could easily be your foot. And and the research he cites goes back 60 years. You guys, this is no alternative practitioner just trying to make a buck. This is about a doctor who for 40 to 50 years studied IC. Then he went and studied, he studied gynecology. He studied IC. Then he studied acupuncture. He studied a whole bunch of other things. And he's the one that's trying to make the connection. He is the one who's trying to understand why patients have recurring muscle tension. Why do so many IC patients, if not most IC patients, have tight dysfunctional muscles? And it might not be what you think it is. Yes, it can be the guarding reflex from a bladder injury, but it could be your toe being screwed up. It could be your foot. It could relate to how your foot is functioning. If your foot is imbalanced, then if your foot is imbalanced, then your hips are going to be imbalanced. If your hips are imbalanced, they're straining the pelvic floor. They're influencing the blood going to the bladder. They're triggering nerves. They're flattening nerves. And he also goes into, this is the part I was reading yesterday. Here's an example. This is so interesting. Look at this. So, this is in his chapter on trying to understand nerve injuries. And so again, this is from the top down, or actually from the front, kind of from the front. So these are our hip bones, and these big structures here, the piriformis muscles, right, that go here and here, and the piriformis muscles attach the sacrum to the hip bone. So the piriformis muscles are the muscles that help you open and close your legs. Right? You move your knee outward and inward. That's directly from the piriformis muscles. What you can't see is that out of the sacrum are actually four branches of the pudendal nerve that are woven through the piriformis muscles. And then, so they are woven through the piriformis muscles, or they emerge into the piriformis muscles. They coalesce into one nerve below the piriformis. Then they go inside the ischial tuberosity, also known as your sit bone, right? And then they come up towards your pubic area. And it divides into three sections. You don't need to know that. But let's look at what a bike seat does. A bike seat, when you're sitting on the bike seat, you're not just sitting on bone. There's exposed pudendal nerve right here. There's absolutely exposed pudendal nerve. That's why this is called cyclist syndrome. Now, again, when you're young, your muscles are very responsive. You probably got more fat down there, and your body is more resilient. But when you're older, and if you've done this for a longer period of time, the chance of pudendal nerve injury are much, much bigger. Right? Muscle nerve. If your muscles are super tight, your pudendal nerve is going to get irritated and injured. And I wanted to show you a picture here. So look at this. This is so important. So this is a healthy nerve. A healthy nerve is round. And actually, a healthy nerve actually has multiple little mini tunnels in it of nerves, because you've got afferent nerves and efferent nerves. So inside this round protective coating, you got, and I don't know if you can really see that, you actually have nerve bundles, right? You can see different nerves inside here. And then the nerves are connected to other nerves through this. If this nerve is compressed by a tight muscle, look what happens. The nerves flatten. The whole thing, it's kind of terrifying, right? The nerve fibers trapped within the compressed nerve sheaths undergo progressive damage. So the compression damages the blood vessels that nourish the nerve. The blood vessels leak into the plasma and the damaged blood vessels leak plasma and platelets into the area that's closed. There's pressure in there. So now we've got things flowing in there that are adding more pressure. It then caught the blood vessels actually irritate the subnerves that are in there. Then we get comprehensive damage, and it just continues. Then what happens? You can see here is when that nerve is compressed, areas of the nerve are exposed. So these are the people who have sudden shocking pain. And then the myelin sheath changes. And so we lose the ability for that nerve to function normally. And then bam. Okay. So I sent this book to a patient that I'm working very, very closely with because I know this is resonating with not all of you, but a lot of you. A lot of you. And I just got a text from him. Hold on a sec. Ooh, there was just a 6-point earthquake in Indonesia. I can't talk right now, but this book has made me cry. So this is a guy who, when he was younger, sustained a massive, massive foot injury, and the insides of his thighs are numb, and they've been numb his whole life. And he suddenly developed what they thought was prostatitis. And now, in hindsight, we realize, and yet, and there's a whole nother story behind that because he got damaged in surgeries and yada yada yada. But coming back to this, I sent him the book and I went, dude, didn't you say you had a foot injury? He goes, yeah. And he goes, you need to read this book. He's stunned. He's absolutely stunned. He talks about when you have a nerve injury. So here's an important. Oh, here's one. Okay, I'm going to read this one to you. Okay, this is Eric's story. Eric's story poignantly illustrates how the simple act of sitting in the wrong chair can inflame and entrap the pudendal nerve with potentially devastating consequences. It also highlights the need to educate physicians to recognize pudendal nerve pathology and make the correct diagnosis when evaluating pelvic pain complaints. Eric was 36 years old at the time of his initial visit with a 10-year history of pain with sitting. He described as the sensation of a golf ball up his rectum and on his perineum. Hello. Haven't we talked about that? Feeling that foreign object up in your vagina or your rectum, that's actually a sign of a nerve injury, right? He described the sensation of a golf ball up his rectum and perineum with soreness at the base of his penis and under the right sit bone. He also mentioned on several occasions that he had experienced pain in the urethra, testes, and lower abdomen. It all began when he sat on a weird chair with a lump in the middle. Since he initially had urethral and scrotal pain with a hesitant and slow urinary stream, he was referred to a urologist who prescribed the standard antibiotics and Flomax to relax the bladder neck. The question Nat answered was why did Eric's symptoms only occur when he was sitting in a chair? After seeing 20 urologists and taking as many courses of antibiotics for presumed prostatitis, the pain with sitting remained. This 27-year-old man in a very lucrative profession had to quit his very lucrative job. He was unable to focus enough to do any work. Fortunately, his wife, who enjoyed sewing, wanted to help, and after much experimentation, she constructed a cushion with a cutout in the center that significantly reduced his discomfort. It then occurred to her to market the cushion for patients with prostatitis who, like her husband, had pain when sitting. It was a stroke of luck for Eric when a patient of mine purchased one of his wife's cushions. The gentleman brought it into my office because he found it helpful for his pudendal nerve pain. I was intrigued with the cushion and thought it might benefit some of my patients, so I phoned Eric's wife to request a sample. When she related her husband's story to me, I explained that his symptoms were not those of prostatitis and suggested that I have a phone consultation with him. He called immediately, and our conversation led to an office visit. Eric's pain with sitting was in the distribution of the pudendal nerve, the perineum, the scrotum, the penis, and the sphincter. On examination, he had very tender skin around the rectum, both with pinching and pinprick. When I touched his left pudendal nerve, it was so tender he almost jumped off the examining table. The diagnosis of left pudendal nerve entrapment was made, and he was treated with a cortisone nerve block. The pain subsided immediately, and he was able to urinate better than he had before. Eric then broke down and began to cry. Imagine having had 10 years of pain, unable to work with a life on hold, and not seeing any further hope for relief. If he had been alive but not living. If it had not been for his wife's cushion that found its way to my office, this young man with a once promising career might have been sentenced to a life in pain prison. Boy, there's something, pain prison. Okay, so again, chicken versus the egg, which comes first? Bladder, pelvic floor, nerve. For some people, it can be the bladder. It could be you drinking way too much Mountain Dew, or you having estrogen atrophy and your bladder can't defend itself. And then, of course, your muscles get tight and a guarding reflex to protect you. So the right therapy is to calm and soothe your bladder by avoiding the irritating foods, and then to give your bladder time to heal. And then we're going to work on the muscles to try to get those muscles to release. Because if we leave those muscles tight, where they're flattening things and damaging and impinging nerves and blood flow, that's a problem. The bigger group are the patients whose symptoms start with a muscle injury, where you've had a baby, a car accident, a fall, a history of athletics, a history of small repetitive issues. For those of you in England, you should know the story of Annette, who Anthony and Annette started the first UK IC Society. And Annette Walker is Anthony and Annette Walker. She could not sit at all, and she was in a horizontal chair. And clearly now we know why none of those bladder therapies worked for her, because she clearly had a pudendal nerve injury. And I have no idea what happened to her. They divorced, the organization changed hands, and yeah, yada, yada, yada. That now we know why she couldn't sit. And if you're one of those people where you have pain with sitting all of the time, you have a nerve entrapment. If you've got numbness, tingling, pins and needles, you have a nerve entrapment in your pelvis. The question now is to try to figure out where it is and why. So he says, so how do we go from a muscle issue to a nerve issue? He says, making a diagnosis of PNE. A red alert should go off if, number one, the patient complains of pain in one or more areas of the pudendal nerve supplies. These are the anus, the scrotum, the vulva, the penis, the clitoris, the perineum, tailbone, sit bone, groin, pubis, and urinary muscles. Number two, the patient complains of pain with sitting that is alleviated with standing, lying down, or sitting on a toilet seat. Number three, the patient cites an activity or an event that could have traumatized the pudendal nerve, including chronic constipation, bicycle riding, squatting exercises, ballet, gymnastic training, one or more falls, difficult childbirth, or pelvic surgery. And number four, if the patient recollects no other causes of pelvic pain, such as viral infection or endometriosis. If the history includes any of these alerts, then it is up to the physician to pursue a PNE diagnosis with a proper examination. So how do we know? There's increased skin sensitivity, there's sensitivity of the skin and underlying connective tissue around the sit bones, which I certainly have, a nerve that is very painful when touched during internal examination, yada, yada, yada. Okay, and then he talks about how you treat it. Talks about buying cars, you know. I wrote a blog on buying cars in 1998 because for 5 years I couldn't sit in a car without crying. And so when I finally got better, and somebody says, do I have regular pain, daily pain? No, I don't anymore, which is thank God. When I finally got to that point where I was better and things had calmed down and started to heal, I drove every car I could drive. expensive cars, cheap, not that I could afford them. I just drove everything to see what I could drive and not cry. And you can find that little blog on our website. The car that didn't hurt me was, in fact, a Buick SUV. And I remember I burst into tears on the test drive because it was the first car in 5 years that didn't hurt. So he talks about, he actually has somebody who comes in and writes something about cars and how to shop for cars, how to treat PNE, gives very specific, he did a lot of nerve blocks. He gives very specific examples of how nerve blocks are done. So you can see he's got his finger in the vagina going by this ligament and nerve, and you can see where the injection goes. Ultimately, for pudendal nerve issues, not only are we going to work on the muscles compromising the nerves, but we're also going to work on the nerves themselves. And he talks about using topical lidocaine, things like that. I mean, guys, holy hell. And then the chapter on IC and urinary syndromes is huge. And again, he explains why the bladder wall breaks down after an injury. It's called, let's see. It's called so let's say you've got a serious muscle injury. He calls it antidromic transmission. It has been demonstrated that when certain high stimulation conditions persist, as with severe sustained pelvic muscle pain, the spinal cord receptors are bombarded with noxious sensory input that far exceeds what they are accustomed to process. One can picture a section of the spinal cord that is literally bursting with toxic neural data. When this occurs, the spinal receptors become overwhelmed and are unable to forward the muscle input to the brain. Instead, the receptors allow the input to spill over to inbound bladder nerves that are carrying their own sensory input. So we now have two-way traffic, afferent and efferent, on a one-way street. A flood of noxious impulses from the muscles is headed directly to the bladder, which is not their intended destination, effectively spreading the pain to an unsuspecting structure. In effect, pelvic floor muscle dysfunction has created neuropathology in the spinal cord, which can in turn compromise the bladder wall lining by creating a pathological breakdown there, which is what I've been saying for a decade. It's so great to see this broken down here. I have concluded that antidromic transmission that allows intense pain impulses from long-standing pelvic floor muscle dysfunction to set off a complex series of changes in the lining of the bladder wall that can culminate in IC. I first presented this theory to the medical community in 2001. And the intervening years of clinical experience have convinced me of its validity. Research supports this concept. In 1998, Pinter and I can't pronounce the guy's name, stimulated lumbar nerves of in a rat to produce antidromic transmission. This resulted in inflammation of the bladder, pelvic organs, vaginal opening, all consistent with what we find in IC. So the question then is, what happens next? And in IC, what happens next is something called degranulation. The pathological influx of pain impulses from the pelvic floor sets the process of degranulation in motion by waking silent sensory nerves in the bladder lining and increasing the number of nerve fibers there. The fiber endings begin to release substance P. Hello, we've talked about substance P before. A neurotransmitter related to pain regulation, and calcitonin. Okay, both of these substances are important players in the pain nerve fiber system. In addition to causing local tissue and inflammation, they cause dormant mast cells in the submucosal tissue under the bladder lining to wake up and degranulate, releasing additional inflammatory substances. The result is the progressive enhancement of bladder sensitivity. This entire process is consistent with microscopic findings of increased amounts of substance P and degranulated mast cells in the bladder lining of patients. We have known that. That's why we give patients an antihistamine to address that degranulation of the mast cells. Anyway, and then he talks about how that leads to central sensitization. Okay, I'm going to read you another patient story. This is Julie's story. Julie came to me at the age of 37 with a history of painful childhood and early adult experiences that led to pelvic floor dysfunction and its consequences of interstitial cystitis and vulvodynia. Vulvodynia, which translates literally into vulvar pain, is the umbrella term for chronic generalized discomfort, such as burning or irritation of the external female genitalia. At the age of 4, Julie sustained physical and psychological trauma when she was sexually abused. At the age of 15, after entering competitive gymnastics training, she was further traumatized when her coach sexually molested her. Then, during her gymnastics competitions in college, she sustained a compression fracture of her mid back and an injury to her low back. Subsequent x rays revealed a fusion of several lumbar vertebrae. She also recounted a long history of constipation, which she attributed to IBS, and mentioned, quote, always having vulvar sensitivity with tight clothing, pain with intercourse, and with deep flushing. At the age of 27, she began experiencing urinary urgency frequency with discomfort in the bladder and was told she had IC. The installation of DMSO in her bladder minimally improved her symptoms. Julie married at the age of 28 and had two children. The first when she was 29, the other when she was 33. 24 hours of labor, including 2 hours of pushing, preceded both deliveries, the second of which resulted in a vaginal tear. Following the birth of her second child, she began to experience anxiety, panic attacks, depression, and suicidal thoughts. When she was 36, Julie began to have vulvar burning and was treated for a yeast infection that was not confirmed on cultures. 1 year later, when all the prescribed topical medications failed to help, she was diagnosed with vulvodynia. Subsequently, she also developed fibromyalgia. So Julie had now seen 5 doctors and tried many therapies, yet the vulvar pain persisted. At the age of 37, she consulted me after reading my article in the National Vulvodynia Association newsletter. During her first visit, we spoke of how her life experiences had culminated in her present symptoms, something she had not previously considered. An internal examination confirmed my suspicion that pelvic floor muscle trigger points and spasm and tender restricted subcutaneous tissues were the prime cause of her urinary symptoms and vulvar skin sensitivity. Julie's treatment consisted of internal and external myofascial release, a home stretching program, a tricyclic antidepressant to help maintain high levels of pain modulator serotonin and norepinephrine. Within 1 month, she was able to walk longer distance and had less skin sensitivity. Within 2 months, her urinary frequency diminished from every 30 minutes to every 90 minutes to 2 hours. At that time, she wrote to me stating, I can now continue my life as usual. And my health is no longer my primary focus. As treatments continued, Julie's symptoms steadily decreased. Within 18 months, she was having periods of pain free intercourse. And within 4 years, she was able to wear jeans and was voiding every 2 hours or so during the day and only once at night. Today, at the age of 46, she is doing well. She's doing so well that she returns to the office only for an annual checkup. Julie's story is similar to that of most patients with vulvodynia and interstitial cystitis. Over a period of many years, her pelvic floor muscles tightened excessively and repeatedly to the point of developing self sustaining trigger points. The series of traumatic events that created this pathology included sexual abuse with emotional stress, gymnastic training, which emphasized over tightening core muscles, a long history of constipation, irritable bowel, injuries to her back, and long labors with perineal tearing. Her generalized body pain, a prime symptom of fibro, occurred because pain modulating dopamine had been depleted by vulvodynia and interstitial cystitis and because of the ultimate sensitization of the central nervous system. Central sensitization brought on by pain signals from trigger points and organ changes in the pelvic region can spread up and down the spinal cord, in turn sensitizing skin, connective tissue, and intestines. The consequence of sensitization is a host of other symptoms. The bottom line, IC is not just a bladder disease. As illustrated by Julie's case, it is a complex response to dysfunctional pelvic muscles, and when improperly treated long enough to engage the central nervous system, it can involve the entire body. Yes, the traditional view is that the bladder is solely to blame for this syndrome, and he disagrees. There are so many patient stories in this, the ripple effect of pelvic pain, different research studies. Okay, here's another one. Sarah came to me at the age of 24 with a 1 year history of urgency frequency. She'd been passing small volumes of urine 12 times a day on average. There was a delay when she tried to start her urinary flow, and once initiated, it was very weak. Sarah also mentioned that she had pain during deep penetration with intercourse, but that the pain subsided if she held still and waited a short time. And for the past 3 months, she'd been experiencing suprapubic pain, a pain above the pubic bone in bed at night. These symptoms began within 24 hours after an intense orgasm during a period in which she was under a lot of emotional stress and holding her urine back for long periods while commuting to school. In spite of negative culture, she'd been treated with 2 courses of antibiotics. Not surprisingly, this failed to resolve her symptoms. A cystoscopy to evaluate the bladder and the urethra was performed and showed no abnormalities. However, the procedure itself gave her excruciating pain. My examination revealed trigger points in the adductor muscles of the inner thigh, the rectus abdominal muscles above the pubis, the piriformis muscles, the quadratus lumborum muscles, which attach the lower ribs to the top of the pelvis. The internal muscles of the pelvic floor, especially around the urethra and the urinary sphincter, were also markedly tender. Treatment consisted of internal myofascial release, a dry needling of the trigger points, uh, um, and the muscle tension quickly resolved within 1 month. Intercourse and orgasms were more pleasurable, and daytime frequency decreased from 12 to 15 to 18 to 8 or 9. After 3 months, 15 office visits, her voiding stabilized at 7 to 8 times a day. Sarah's history includes a long string of early traumas to the pelvis that could progressively increase muscle tension in the affected areas over time. At the age of 7, she slipped on a large wooden plank and landed on her vaginal area, resulting in bleeding. At the age of 16, she was kicked in the crotch and another time was punched in the clitoris. The resultant pain was so severe she was unable to walk for a day. At the age of 19, she injured herself and lost consciousness after slipping on the side of a swimming pool. She was a gymnast at an early age, and at 19, she began dancing vigorously. This resulted in pain down her left leg and lower back, which she attributed to an injury to the sciatic nerve. As one incident after another occurred, trigger points formed. All or most of them appeared to have remained latent or asymptomatic. The only indication was problem with pain down the back of her leg. Uh, One day, these tight, strained muscles were put to the ultimate test by a vigorous, prolonged series of contractions from an orgasm. Muscles around the urethra and the rest of the pelvic floor went into a sustained, severe, self perpetuating spasm. The result was urinary frequency, urgency, diminished urinary flow, discomfort above the pubic bone, and pain with intimacy. Sarah's story just demonstrates how cumulative stresses and traumas to the pelvis can eventually explode into severe, sustained symptoms when a critical threshold is crossed. It also demonstrates that urinary symptoms are more likely to reflect what's happening outside the bladder than inside the bladder. It also demonstrates that urinary symptoms are more likely to reflect what's outside of the bladder than inside the bladder. Therefore, practitioners are advised to evaluate and treat accordingly. Okay? My friends, my friends, please, please get this book. Get this book. Especially if you're not walking normally, you've got scoliosis, you've got one leg longer than the other. If you have sustained any major traumas from a broken foot to a broken hip, you've got to get this book. Okay. Now, listen, I can go on and on. I still have 150 pages to read. I'm going very slow. It talks a lot about perineal pain, tailbone pain, pain with orgasm. Those are sections I haven't read through yet. All right. Let me take a drink of water and let's go back through your questions. You know, I think about my history. So let me think. I first had frequency urgency in 7th grade. I could not sit through class. It was a big deal. My teachers got pissed. I kept asking to get up and use the restroom. I was referred to a urologist, Dr. Andrew Thusen, chief of the medical department at Memorial Hospital in Santa Rosa. This was in the 1960s. My first x-ray was an IVP. And I was in his office, sweet nurse. We took an x-ray. It was just her and me. So she has me stand in front of the plate, takes the x-ray. She goes, "Hey, you want to see it? Come on into the room. Let me show it to you." I go walking into the room in my gown. The x-ray pops up. I have a curve in my back. She goes, well, look at that. You have a curve in your back. And I say to her, oh my God, I must not have been standing up straight. Let's do it again. I'm going to stand up as straight as I possibly can. So we go back to the x-ray. I stand up as straight as I possibly can. Takes a picture. We go back. Guess what? Curve's still there. And that was the first sign that I had developed scoliosis. Now, from the urologist standpoint, the urologist is looking at the bladder. So what did they do back then? They did what they did in the 60s, urethral dilations. I had a urethral dilation a week for 3 years. That's where they stick a rod up your urethra, stretch your urethra. You've got anesthesia. I was breathing into a mask. You just go, and then turned out he was doing rescue installations at the time. He was one of the first to do it. Then he filled my bladder with lidocaine and I was able to go home. And that's all they did for patients with frequency urgency back then in the 60s. So they did these urethral dilations. But the question is why was my urethra narrow in the first place? It was like trying to pee through a needle. The answer probably goes right back to the scoliosis. My scoliosis appeared I had a huge growth spurt. And I was chubby back then. I was pretty chubby. I had big boobs. I mean, in junior high, I was one of the tallest girls in school, and I matured quick, and I had big ones. And I think that my breasts were so big and so heavy that my spinal cord couldn't support the weight, and that's why I developed an S curve. So using this book, what this book is saying is your bladder's healthy, and my bladder looked absolutely healthy. The only thing that was weird was that my urethra was narrow, it was constricted. And the question is why? And so what this book says is, you know what? It was probably the scoliosis. The scoliosis causing one hip to go off, the resultant pelvic floor imbalance causing those muscles to contract, squeezing my urethra. So then the question is, well, then why did my sister develop the symptoms 5 years later? So again, we always think genetics at play. Well, my sister was a horseback rider. I rode horses a little bit, but she was a really, really good horseback rider. She did shows, 3-day events, things like that. And so now I have to wonder if she had exactly the same issue, only her pelvic floor is injured by instead riding horse. And Sue, if you're in here, makes you think. Alrighty. So let me go down to Amazon here first. And I'm going down to YouTube here first, and I want to. Gabby says, I have scoliosis and have this problem in my feet too. I can't believe it. I know, right? It's crazy. So Gabby says a doctor recommended swimming or yoga. And so here's the issue. He talks about appropriate exercises. And if you've got a pudendal nerve issue, swimming is fine, but you can't use your feet. If you use your feet, you're going to stress the nerve. Okay. And so, and also they don't want you squatting down greater than 90 degrees. And they also don't want you bending over 90 degrees, which is going to cause your glute muscles to stretch in the back, which is going to push on your pudendal nerve. Gabby says, I'm realizing that my symptoms started when I started running in the park 3 times a week. I have to tell you, I have not been able to jog ever since I was playing tennis. I could play tennis. I couldn't jog. And now it just hurt. My knees hurt. And now I think I know why, because of that freaking Morton's toe. Hi, Alan. Kat says, just ordered the book. Kat says, reminds me of the chicken and the egg with TMJ too. So Kat, he absolutely talks about TMJ in this book. I have TMJ. My TMJ's been really bad. Like the last 3 months, my TMJ has been like, I haven't been able to eat tortilla chips because, which side is it? It's my right side. The tendon will lock my jaw if I get to a certain point. Is that right? Anyway, so TMJ is actually, they do believe that TMJ can also begin in the feet with Morton's toe. It's like crazy, my friends. It's freaking crazy. So Kat says, when I was studying for TMJ in the early 70s, the doctor showed me how my jaw was lopsided and so are my shoulders and hips. Okay. So that's got to be playing a huge role in this, Kat. Got to be. All right, let's go to Facebook. Alan, your symbol is hysterical. All right. Okay, so you guys with Facebook, just know that I can't scroll back. And so I have probably missed a massive number of questions. And I'm just going to tell you right now, if you stick around to the end, I'm giving away this book. $35 book I paid for out of my own money is going to be our door prize for this meeting. I'm expecting them tomorrow. And so our door prize for this meeting is going to be this book, probably 2 copies of them. We'll see. And then I also have 2 heating pads that were made by Angela. And she had the fabric printed up. You see, it's got bladders on it. It's hysterical. She had this fabric printed up with bladders and IC awareness things. So I have heating pads to give away too. But man, you got to stay till the end. Okay. So we've been having some discussions based upon, what we know now here with this about Hunner's lesions, right? Because Hunner's lesions are, the theory behind Hunner's lesions is that it is a nerve that is massively, massively inflamed. That's releasing all those irritating substances like substance P, which is causing the tissue to break down, or it could be a virus on the nerve. And I have to tell you again, this book supports the nerve theory completely, that this patient's nerve is massively compromised in some way, which is leading to that nerve damaging tissue. And it would explain why lesion specific therapy and killing that nerve by cauterizing it makes symptoms go away because you've targeted the nerve. Anna says, I changed to a car SUV as low riding cars were too bumpy for me. I also have scoliosis, one leg shorter, and all of my muscles around my left hip are hurting. Anna, me, it's my left hip too. I also at a young age injured myself on a bike and go to a specialty gynecologist that has recommended pelvic floor therapy. Girl, she says she's too chicken to go. Girl, go to the pelvic floor physical therapy. It's amazing. It's amazing. It works so well for some of us. And the reality, hey man, you're speaking to somebody who has scoliosis. I think I can probably show you mine. Let me see. If I bend so if I bend over, you look at my back and you're going to see one side of my back higher than the other, right? Can you see that? That is because I have an S curve. I'm 5'9", I'm supposed to be 5'10". I sure would like that inch because then I wouldn't have all this stuff around my waist. But anyway, so my curve is an S curve like that. And there's no doubt, Anna, that your muscles think about the curve. The muscles on the outside of the curve are overstretched. The muscles on the inside of the curve are contracted. I always thought that the secret to improving scoliosis was to tighten the muscles on the outside of the curve and release the muscles there. And that's what I've done. Here, hold on a sec. That was somebody who's going to deliver more heating pads. Sure. Okay. All righty. So please, please, please go. And again, Anna, listen, you've had muscle issues for decades. It's not going to go away overnight. This is about you trying to improve the balance of your body, improving your core, getting, it's real interesting when you got scoliosis. Hey, actually, if I can take a moment, we need to thank our sponsor for this stream, Preleaf, DSC Healthcare Solutions. Preleaf is the most popular supplement ever used by the IC community. It is an acid reducer. If you've got bladder wall injury, bladder sensitivity, acid sensitivity, Preleaf is a little calcium pill that will reduce acid in your urine and make your urine less irritating. And it has helped thousands of tens, hundreds of thousands of patients over the years eat foods that might have irritated their Hunner's lesions, or if they had bladder wall sensitivity, their bladder. Like any supplement, you do not eat these like candy. It is calcium, and that calcium has to go somewhere, and it could lead to kidney stones and other issues if you do too much. So, really, just follow the manufacturer's instructions, 1 or 2 pills before a meal, and you're gold. All right. Now, there's some people out there who are already prone to kidney stones, and you can't do Preleaf. But if you've never tried Preleaf before, it's been out for 30 years, created by Dr. Alan Kligerman, the same guy who developed Beano and Lactaid. The science behind this is impeccable. All right. You can get this on Amazon or on the IC Network. All righty. Mary says, this is overwhelming, but I truly believe there has to be a way to get well. Oh, absolutely. See, that's the thing. That's the thing is when Chris Payne developed his subtypes, remember what he said? He said how unfair it is to tell patients this was incurable bladder disease, when in fact, some of these subtypes are curable. Pelvic floor is curable. It is curable. And we see cures. We see patients going into decades long remission if they get the right therapy. But of course, you can get injured again. You can get injured again. And if you get injured again, you're going to be more vulnerable. So somebody's asking about Christine Whitmore. So word has it she is affiliating with another clinic. I don't believe it's opened yet. I'm not sure if it's in Philly or not. When I get the info, I will let you know. Vicky says, who do you go to that can even help? Number one, Vicky, you got to go have a pelvic floor assessment. These doctors are few and far between. You know, if you can go to your gynecologist, and if your gynecologist finds that your muscles are tight, they can make a referral to a pelvic floor physical therapist. But you got to do your homework. You cannot assume that most physical therapists know about this stuff. Physical therapists generally are taught how to deal with incontinence, which is about tightening muscles, strengthening muscles. If your muscles are weak in your pelvic floor, you're going to be fecally incontinent or urinary incontinent. If your muscles are tight, you're going to struggle with being able to pee or being able to have a bowel movement. So generally, if you go to a physical therapist and they go do Kegels, they don't know what the hell they're doing, because you only do Kegels if you're dealing with incontinence. You do reverse Kegel. You do very different types of pelvic floor stretches and physical therapy when we're dealing with tight muscles. And so you give the physical therapy a try. Do you feel better? Do you feel worse? And let me just say here, and he talks about that in this book. If you go to the physical therapist and it hurts, hallelujah, baby. Hallelujah. They found it. They've touched it. That is the best news ever. If you can go to the physical therapist and they do an internal exam and they can reproduce your pain, do not be scared. Be thankful. That means we have isolated the problem, and the problem is going to be one of those pelvic floor muscles and or a nerve that pelvic floor muscle is compressing. So don't be afraid of physical therapy. The entire point of that pelvic floor assessment, which is generally 45 minutes long, is they study your body from head to toe. They're going to look for muscle tension. They're going to have you walk up and down a hallway to look at how you're walking. They're going to measure your legs, see if one leg's longer than the other. They're going to look at your core. They're going to look at your butt. They're going to look at everything. Look at how your body is functioning. And then they're going to do an internal exam, rectally for men, vaginally for women. And all they're going to do is just gently touch muscles. And if in the process of gently touching muscles, they can trigger your pain, hallelujah. This is spectacular news. It means they found it. And when that happens and you go, ow, you're going to go, that's it. What are you touching? And you're going to get the name of it, because that is the beginning of treatment. You can't fake it. You guys, a lot of you are going to say, "Well, I'm just going to start doing Kegels." Please don't do that. You're going to hurt yourself. This is something you cannot figure out on your own. Yes, you know your muscles are tight, but there's no way you on your own are going to be able to figure out which muscle is the freaking problem. You have to go to a physical therapist at least once, please, and have them touch your muscles, because remember, your pelvic floor is a bowl. So you've got muscles along the base, and you've got muscles, I always say you got muscles to go from left to right, front to back, low to high, and that's true. But like my physical therapist, she kept saying, "Jill, when you're doing your internal work, do a J. Do a J with your thumb." She wanted me to use my thumb in my vagina and and do this, go upwards in a J motion, right? And I just like didn't really get it. I didn't, because like I did not do the cadaver class in college. I didn't want to look at dead bodies in college. And so I just couldn't do it. I just didn't want to do it. And I don't think I really understood how round the pelvis is. In a guy, the pelvis is narrow, is much narrower. In a woman, and in a guy, the pelvis is really thick, heavy muscles to support the heavier weight of a man. In a woman, our pelvic is wider and lighter and thinner, and it's more vulnerable because of that. It's really, really, it's so interesting. Shani says, okay, so anyway, Vicky, you go to pelvic floor physical therapist, have a study your muscles, and please read the book before you go. Please read the book before you go so you know what you're dealing with here, so you understand the muscle positions. And then you give pelvic floor a try, and if it helps, fantastic. Keep going. But if you're dealing with constant chronic muscle tension, we have to look at bony structures. If you're dealing with nerve pain, if you've got areas of numbness, then we also have to deal with nerves. That you might have a muscle so tight it's compromising a nerve. Cheney says, I fell, I have a pinched nerve, herniated disc, slight curvature, but that is because my feet are bad. But I hit my tailbone on someone's porch. It hurts so bad. A year later, I started having bladder. Exactly. So the odds are, Cheney, you have, so you probably have accumulated trigger points along your levator ani muscles. It's called ani for a reason, because they go from front to back all the way up to your rectum. And the levator ani is a group of muscles with different names, but I can show this to you. Okay. So look, this is the tailbone. So this is the back. This is the front. And so the levator ani is actually a group of 3 muscles. And you see this one muscle comes from the front and then goes all the way back and attaches to the tailbone. But then you've also got this muscle here, which is the coccygeus, which also attaches to the tailbone. So Cheney probably, and then of course you got the piriformis right here. So you probably injured one of these muscles, and they've now got trigger points on them. And those trigger points are now pulling and pushing and compressing and doing things that ultimately led to you having bladder issues. Now there comes a time too when you've got to go talk with an a physiatrist, or an osteopath. Less so an orthopedic surgeon, but somebody who works with big bones and muscles. The physiatrist would be do it. Laura says, okay, I am textbook foot and hip issues and Morton's neuroma. Can someone, for the love of God, tell me what specific insert? It's not an insert, Laura. It's not an insert. It's a pad that gets put directly underneath your big toe. And if you get the book or you Google it, you will find it. Okay. It's not an insert. I went to Happy Feet, got their inserts, just about killed me. And ultimately, in the end, you got to go work with a podiatrist. Really try to understand what the heck's going on with your feet. Laura says she had urethral dilations as well. Yeah. Oh man, I had so many dilations. I don't know. I mean, they didn't bother me after a while. It was like, I think it was a psychosomatic response where I just felt better. Uh, but I was a pretty tough kid to have my urethra stretched every week. And I had the only anesthesia I had was they gave me the same thing, laughing gas. So I breathe into a mask for about a minute before they did it, but it still hurt like hell. I mean, it hurt like hell. Yvonne says the IC pain began after hip injury, but you were told you have hunters. So that's okay. So if you got hunters, you got to treat hunters, but you still got to work on the hip thing. Darlene says they told a lot of us we had a small urethra. Yeah, he talks about that. That's the only thing they had back then. Hello, Paul. Sherry says endometriosis throughout my pelvic area was a big problem before my hysterectomy, although cleaned up with surgery, but I wonder what scarring remains, giving me further pain. Exactly. John says, I was told Whitmore was in Europe serving on a panel. She was. She was over at the ESSEC meeting. Vicky says, I used to be a runner, had no issues with knees. You have Morton's toe. Yeah, but Vicky, do you have scoliosis? Because I have scoliosis. Hi, Lori. John says, I have so many of these symptoms. This is John, right. John, seriously, when you read and study the pictures for men in this book, you are not going to believe it. You're not going to believe it. Jennifer says, so happy this first time I'm catching you live. Yeah. Sue says, looks at your toes. I've been curling my toes for my entire life and have plantar fasciitis. I am so getting that book. Yeah, it's stunning. Sue says, can you show on your foot exactly where those quarter-size pads are? John says, today's session has been overwhelming to say the least. Hey man, I have been reading every night. That's why I'm reading everything twice. Sue says, I love your leggings. Thank you, Sue. Gee, whoever picked them out sure had great style. Who could have that been? Okay, so this is an example of the pad that you would use. You can see the outline of my toes, right? Because I wear my shoes a little bit longer. So look, there's the pad of my big toe, and this is actually where the first knuckle goes. Um, and anytime you've got the little hammer toe on the second toe, that means your second toe is trying to grip when it's not supposed to be gripping. And that could explain everything. Jana says, I was so happy I tuned in today. I was hoping you would address the topic of pelvic pain. Well, I was so impressed with the book you talked about. I just ordered it. I'm sure it will have the answers. I've been trying to get, Dr. Weiss, he closed his practice last year, and I want to interview him. I want to video him. I want to do everything I can with him so that we can get this. I feel so bad that I've met him several times at meetings. I did not know he was doing this work to the degree that he was doing this work. And because I'm in Kaiser, I never had the chance to go see him anyway. But this book is a love letter to his patients. I have never seen a book written with such love and kindness and caring and compassion before. And in the end, in the beginning, he really explains how medicine has failed us. And it's failed us because it compartmentalizes the structures in the pelvis. The bladder does not exist on its own. The pelvic floor does not exist on its own. The nerves do not exist on their own. And to only look at the bladder or only look at the reproductive tract or only look at the muscles and not consider their influence on each other, especially neurologically at the spinal cord, is the mistake. And for those patients where you've done bladder therapy after bladder therapy after bladder therapy and nothing is working, what does the American Urology Association say in their treatment guidelines? If you're not responding to therapy, if you're getting worse rather than better, if your symptoms keep coming back, revisit the diagnosis. Let's make sure we know what we're treating here. And he's explaining what else it can be beautifully, to the point that I know I've always thought pelvic floor is the biggest subtype. I think pudendal nerve entrapment, pudendal nerve injuries are probably higher than direct bladder wall injury. I do. I do. Jennifer says pre-leaf has helped a lot. Hello, Beatrix. Allison recommends pre-leaf, highly recommends. CM Widow says, my doc is Alyssa PT. She knew and trusted. I think I got a blessing there. John Lee Mine gave me 4 names. She trusts no one else from me. Says there's a lot of who are not good. That is so true. Dragana says, can subtype 1 be cured? So subtype 1 Hunter's lesions is one of the great mysteries. And we kind of talked about that here. And I've had a lot of conversations with people about that this week based upon this book. And that is, you know, what triggers the development of a Hunter's lesion? Now, if it were a direct bladder wall injury, why would it only occur in one spot? Wouldn't the entire bladder or major portions of the bladder be affected? And the thing with Hunter's lesions is sometimes patients just have 1 or 2, right? And they can be in different parts of the bladder. And we know that generalized bladder therapies don't work for Hunter's lesions, like Elmiron. They wouldn't touch it really with a 10-foot pole, or a rescue installation might help for numb it for a couple of hours, but it's not going to fix it. So the theory behind Hunter's lesions is, number one, it's just a nerve that is massively, massively inflamed, issuing a lot of substance P. Or number two, it's a virus living on the nerve, because we now have research studies from Europe, which has found a couple of different viruses in the urine of patients with Hunter's lesions, most recently the Epstein-Barr. So we're thinking either viral infection and or nerve injury. But what we do know is when lesions are treated directly, the pain usually improves dramatically. And in fact, Lyris was the first treatment in history to heal Hunter's lesions after just 2 weeks. And we would potentially consider that a cure. Oh, see, now look, what did I just do? I just put 1 foot up on my chair, which is an absolute no-no when you've got pelvic floor issues. I used to sit on 1 foot all the time, and you're not supposed to do that. That creates imbalance in the pelvic floor. God, I'm fat today. Not that you needed to know that. I feel fat today. Oh, must have eaten something yesterday. All right. Trudy says, I'm new to this, I see, so happy to find this network. Welcome. Sue says, I missed the first part. What is the name of the book? The name of the book is Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Molly said, I've had scoliosis since I was 10. My bladder has been found to be healthy, yet I've gotten sicker since cystoscopy in November. Can't walk very far. Sleeping a lot. Takes 15 minutes or longer to pee. I'm frustrated and feel alone. All right. So, Molly, you got to get the book and read the book. I have a feeling your bladder is if your bladder is healthy, then we have to look at muscles and nerves. And this is very, very encouraging. You should be very encouraged by this. And Molly, the fact that you can't walk far, that points to muscles. You can't take a bus, you can't sit very long, that points to muscles and nerves. You've been crying for days. Okay, now here's the other thing. Here's the other thing that he talks about, that again, I mean, I knew, but I really didn't know why. The pelvis is really, again, like I said before, the core of the fight or flight response, right? I mean, it is the center of the body. It is the brain communicates down the spine through the pelvis to the legs so that you can run. And if we go back tens of thousands of years, when we were all living with saber-toothed tigers, we had something called the fight or flight response. And that is, if we were confronted with a stressor, we needed to either be able to run away from the stressor or fight the stressor, right? And it's a very visceral response. Now, Molly, one of the things that he says, and I knew this, but I hadn't seen it explained this way, is that the nerves in the pelvis communicate to a very visceral part, a very ancient part, not visceral, an ancient part of the human brain. What did he use? He used the word something like prehistoric, something like that. One of the oldest centers in the brain. And so it's obviously a very deep, fundamental core bodily function, that the pelvis be able to communicate with the brain so that, and the brain be able to communicate with the pelvis so that we can run or fight if we need to. What's interesting about that is it happens to be right next to the limbic system, which controls your emotions. And so it's very normal, and we've known this for years, that I see patients with bladder pain and pelvic pain would cry a lot. And of course, bladder pain, pelvic pain, especially bladder pain, if you've got a real bladder injury, is characterized by being relentless and difficult to ignore. It pounds away at you. Normally, if you were to fall and skin your knee, you might feel pain for a couple of hours, and then life goes on. But organ pain, this type of deep pain, is characterized by being relentless and difficult to ignore, and he explains why, because now we know that it goes to a different part of the brain, and that brain is right next to the limbic system. And so pelvic pain is going to trigger anxiety and depression. Not It's not a personal failing of yours, it's that the nerves themselves are being stimulated. They're being stimulated by by nerves. I mean, and so it's kind of an accidental thing that's happening. Um, Hold on a sec. But he also talks about viscerosomatic and somatic viscero, or efferent afferent, right? Okay, so remember that your central nervous system is your brain and your spinal cord, and it relies on your peripheral nervous system to deliver messages. So if you put your hand on something hot, it's the visceral nerve up your arm that goes to your spinal cord, that goes to your brain, and then your brain send another nerve back down to your motor nerve to move your hand. Motor means move, right? Motor means move. So you've got sensory nerves, which your body uses to just sense the environment, make sure everything's okay. And then if your brain finds something abnormal and that gets up there, your brain immediately signals back down to your motor neurons to do something different. To do something different. Anxiety, and we remember we learned this in another book that came out called You Don't Have to Live with Chronic Pelvic Pain. Anxiety, so we know that if you have pain and that nerve and that the pain nerves come up to your brain, it's going to trigger anxiety. That makes sense. I mean, who wouldn't be anxious to be in pain, right? But it also turns out that patients who have anxiety issues before everything else, let's say somebody who is sexually abused, or somebody who has been, somebody who has some sort of issue going on there, that long-term anxiety can also do the reverse. Long-term anxiety and stress can also lead to the dog putting his tail between his legs, which is what dogs do when they get stressed. And we do the same thing. When we're stressed, we tuck our pelvic floor under. And so part of this treatment process is it's obviously looking at nerves, at organs, looking at muscles, looking at nerves. Um, and in the same context, we want to make sure that there's not any persisting anxiety, depression, which is going to trigger you to walk with your tailbone, tucked underneath your pelvic floor, rotated under. And so we want to make sure that those patients who are struggling with anxiety get some help for that. Like I did. I mean, I got help for my anxiety. I had terrible anxiety when I was younger, and took some anxiety management classes that completely changed my life. But he again explains why allowing recurring anxiety to continue even after we fix the muscles and we fix the bladder, if that anxiety is still firing massively, you're still going to be walking with your pelvic floor tucked, and you're creating more pelvic floor dysfunction, more latent trigger points. Then you're going to step the wrong way off of a step, and bam, you're going to turn all those trigger points on, and you're going to be right back into pelvic pain. I hope that makes sense. John says urethral dilations can cause eventual scar tissue. I mean, I probably had 100, and I asked them about that. I've asked every doctor as an adult. I mean, when my IC started when I was 32, when I first had bladder pain, I actually wrote that orthopedic surgeon that diagnosed me when I was a kid, and I said, "Hey, do scoliosis patients have bladder problems?" And he never responded back to me. But I've had every doctor who's ever examined me down there look for scar tissue, and they never found any. And I think that's because the guy who did it for me was a master. He was a master. He never. The only time I ever bled after a urethral dilation was with another doctor. I had like two with this other doctor after my doctor had retired when I was like in junior college. And I never went back. If I bled after urethral dilation, it means he didn't know what he was doing and he tore tissue. So with a urethral dilation, remember your urethra is like the sides of your little finger. And when I had them done, the doctor used a male dilator that was, so it was like a long pipe in a J shape, in a reverse J shape like that. And so what he would do is he would numb the urethra, then he would stick the dilator in, and then he had an IV bag filled with lidocaine and heparin, and he immediately put that into my bladder as soon as he dilated me. And now we know that's a rescue installation. They were doing that to me in 1970. And I think that's why. The other dilators were this rod, this metal rod with a screw on the end. So they stick the rod in and then they just screw it tight, open and open and open. That's the one that tore me. So I never went back for that. And we don't do. Somebody at an IC at a American Urology Association conference, at one of the IC classes, a foreign doctor asked one of the speakers, "Do you do urethral dilations?" And the speaker said, "We don't rape the bladder we don't rape the urethra anymore." So most doctors do not do urethral dilations anymore, to the point that they called it raping the urethra. Jennifer says, "I don't remember ever having an injury. My problems all started at 11 when I started getting my period. I'm now 44 and I had a total hysterectomy and I still have IC." So Jennifer, think about it. When you're 11, are you riding a bike? Were you riding a bike? Because if you were riding a bike, you were pushing right up into the nerves and the muscles. All it takes is jamming your crotch on the bar of your bicycle once, and you could have those latent trigger points that then got added on over time until they became a problem when you were older. Emily says, "What about when they fill the bladder up under anesthesia and it gets inflamed? Which type would that be?" Well, a hydrodistension with cystoscopy is already known to damage the bladder. When you stretch the bladder with fluid, you're going to damage the bladder. And that's why the hydrodistension is no longer the gold standard way of diagnosing IC, because we now have research that proves the hydrodistension itself can damage the bladder wall and cause petechial hemorrhaging. And so a hydrodistension is only done if the diagnosis is in doubt. It is only done if a doctor is trying to figure out what the heck is going on with you, and they rule everything else out and they need to look at the bladder. That's when we do a hydrodistension, and it should be low pressure, short duration. It should not be big. It should be a minor, less invasive procedure. Cynthia says, your son is a doctor of podiatry. He wears Hokas and highly recommends them. We'll get the book. John says, "I've had surgery to remove some scar tissue resulting from repeated dilation." I believe it, John. I mean, honestly, especially for men, because your urethra is a hell of a lot longer than mine. So the odds of you, oh, see, look, I almost did it again. I almost put my foot underneath my butt again. Oh my God. I'm learning proper pelvic floor. Hey, I want to show you this chair too. Let me show this to you for a minute. I mean, like I have probably spent $5,000 in office chairs in the last 10 years. I just have, I've had so much pain when sitting. It's gotten worse and worse and worse in the last 10 years. And it's always on my left side by my left SI joint and my left piriformis muscle, right? And so the last chair I bought 2 years ago was a lazy boy kind of real. I've always gone for thick cushioning, right? But this chair came out, and I don't know if you'll be able to see it or not. Yeah, I had to get the fabric one. Here, let me turn on this light. I don't know if you can see this or not. This the the seat itself rotates, and so when you're sitting up, you've got perfect back support, but then it will also rotate. And I've been using it for about 4 days now. It's pretty good. If you saw in the other meetings, I always had a big cushion behind my back. With this chair, I don't need the cushion because it's going right back into my lower lumbar. And so this is what's it called for anybody that's interested? Here it is. An all 33 back strong chair. And I have to say, it was really easy to put together. It took like 10 minutes to put it together. Couldn't have been easier. So all 33 for anybody who's, trying to find a chair that they can sit in comfortably. Because I want to work, baby, because I like my job right now. I like especially meetings like this, new resources like this, so exciting. Yvonne says, here I was thinking I need to have my bladder removed. Now I know it has to be pudendal neuralgia. And he tells the story of that. Yvonne, he tells the story of patients who had their bladders removed only to discover afterwards it was pudendal neuralgia and other things. Beverly, how do we get the book? It's over on Amazon. And you guys, I want to be crystal clear. I am not being paid for this in any way, shape, or form. When you buy it, I'm not getting anything from it. I haven't talked to this doctor in 5 years. I saw it announced last month on Amazon, and I went and I just went, I want to read his book. And I honestly think this book right here is the best book ever written for IC and pelvic floor and pudendal neuralgia. Remember, we have subtypes. We cannot make sweeping statements that everybody is the same. So there were a couple people in here who basically said, well, I don't believe that. And it's like, it's okay if you don't believe that, because some people have viral infections. Some people have genitourinary syndrome of menopause. That's okay. But for a lot of us, muscles matter. Mari says they don't treat the body as whole, but by sections. That is why there's never a door closed. But Dr. Bergman explained it so well, and he's corrective care. Yeah, exactly. I just don't think I really, really, really understood the depth of the connection and interaction between everything. Allison said, I had 6 lesions last January treated with diathermy, but I think some have come back. So, so again, Allison, number one, it might be interesting to have a next generation urine test to see if you have any active viral infections. See if they can find the Epstein-Barr in your urine, and if that's the case, then they could give you an antiviral medication for that. And if they do not find virus, then again, I think in your case, it's still important to look at nerves and muscles. Dragana says, oh my, I had mononucleosis and everything went downhill from then. Thank you. Yeah, that was last year. We learned that the monovirus Epstein-Barr is found in the urine of many patients with Hunter's lesions. Christine says, which book? This book, Breaking Through Chronic Pelvic Pain, a Holistic Approach for Relief. Please, please, please link this to all of your IC groups online, all of them. This is holistic. So even the groups that don't want to talk about traditional therapies, this book does not talk about Elmiron. It does not talk about traditional therapies in any way, shape, or form to that degree. It talks about the reason why muscles and nerves and everything else can trigger these symptoms, and it is truly a holistic approach to therapy. Talks about acupuncture. I thought that was a great discussion on acupuncture and why that's so helpful in breaking up trigger points and stuff and kind of restoring balance and flow. I'm going to go back and I'm going to try some acupuncture for my left pain. John says lidocaine can be irritating. Your doctor doesn't use it. Yeah, it can be for some people. That's why they go to Marcaine. And it might even be back, so like, remember, I went to Walgreens yesterday because this is really making me reconsider all of my pain, right? I don't have bladder symptoms at all really now. I mean, like I can have coffee almost every day and I'm okay. I'm okay. What I have is a buzzing feeling in my left butt cheek. Even right now, there's a minor flickering, like right on the inside, right around my sit bone. And I've been talking to the doctors. What is this? Is this a nerve or is this a ligament? I think based upon reading this book, I think it's a ligament. And I'm going to go have some prolotherapy. I'm going to ask if I can have prolotherapy on that ligament to strengthen that ligament. But anyway, so he talks about when he does this examination, not only is he looking at muscles, he's looking at skin. And if your skin is tight, if your subcutaneous tissue, which is a tissue directly underneath your skin, if it's tough and rigid rather than soft and flowy, that is a sign of a nerve injury. And so a very big part of dealing with a nerve injury is turning the pain off. And so for my vulvodynia, they gave me, that happened last year, they gave me estrogen cream and lidocaine in a petroleum base, Vaseline base, and that really worked. I don't have that vulvodynia anymore. And if I feel anything, any little prickle, I immediately use it because I want to stop that nerve. I decided that I wanted to get something like this, a roll-on lidocaine gel that I'm also going to try to use over that left side because I have a lot of skin, like he says in the book, touch the skin over where your pain is. And so, my dominant pain is right here, right? And when I touch and roll that skin, it is quite tender. Whereas if I touch this skin right here, it's not tender. It's not tender at all. And so you'll see in the patient stories that they really make an effort to try to calm that nerve down in a variety of ways, from nerve blocks with lidocaine to topicals with lidocaine. So I got the Salonpas with lidocaine. I thought I would give that a try over my left butt cheek. I also got some an arnica gel to use. He talks about arnica to a degree, and he talks a little bit about homeopathy, that homeopathy might help in mild cases. What else did I get? And then I got, okay, so right, like I got the foot pads. I got the foot pads because right now for that Morton's toe, I'm using a very thin pad, but they said that you actually cut a circle out of these foam ones. And then I got the tape to attach it to my foot if I want to attach it to my foot, or if I want to attach it to my insert. Got a couple of different types of tapes. There's another tape I got. Oh, okay. I also got some dry mouth gum, Biotene dry mouth gum, because I've been my tongue has been kind of sensitive. And my tongue gets really sensitive if I get dehydrated. So I got dry mouth gum, and then I also got Biotine moisturizing gel for nighttime. If the sides of my tongue start getting sore, that usually just means I haven't drunk enough water. Speaking of which, this is pumpkin spice rooibos tea, completely bladder friendly. I don't do, if I'm going to do coffee, I'm going to do a decaf low acid coffee. I'm older now. I have genital urinary syndrome of menopause. It will not help me to drink something caffeinated and acidic, that's for sure. Leela, anxiety, stress, PTSD, constant worrying. I know this caused my IC. If it was dormant, my life choices, bad events. Girl, we are all works in progress. Absolutely. I am proud of you. I am proud of you for working on it. Good job. Keep it up. Sue says she went through urethral dilations in her 20s, and she's unbelievable what women used to have to go through. But guys went through too, as John said. Karen, Karen, I've spent 2 hours talking, 2.5 hours talking about this so far. You'll have to watch the first hour of the recording to really get it. Ultimately, it's in, oh God, this new book is the best book ever written on IC. I'm just telling you right now, ever, 100% ever. If there's a book that you should read and absorb over and over and over again until you get it, it is this book. I mean, I've read it twice so far because I wanted to read it twice so I really understood the concepts and I could talk about it clearly. And even then, it's still a little bit hard to talk about. I'm putting it all together like light bulbs are turning on that never turned on before. And in essence, he frames the pelvis in a very, very different way. He talks about how the pelvis is the buffer for the human body. The pelvis connects the top from the bottom, right? The pelvis carries the weight of our abdomen, the weight of our arms and our heads, and our shoulders and all that sort of stuff. And it just carries our upper weight, travels through the pelvis and down to our legs, right? And so as we walk, it's the pelvis that kind of controls everything. It's an organ of balance, for lack of a better term. And it does that in a very, very intricate way because the pelvis does not exist on its own. The pelvis has deep connections to the abdomen. We've got abdominal muscles, the psoas muscles that go from your ribs down to your hip bones and your tailbone. And then we've got muscles from the legs that go up into the pelvis, like your thigh muscles. And so any injury that happens above the waist and or any injury that happens below the waist is going to impact how it functions, how the pelvis works. And we talked about subtyping, these 5 variants of IC: Hunter's lesions, bladder wall driven, pelvic floor driven, pudendal neuralgia, and central sensitization, right? Those are our core variants for this. And he brings up things that have never been brought up before about what can trigger long-term pelvic dysfunction that can lead to bladder symptoms. And he describes very clearly how it happens. It's the chicken versus the egg. For some people, IC begins with a bladder injury that then triggers the pelvic floor. For others, IC can begin after a muscle injury that can eventually trigger the bladder. And he explains a molecular process of how that happens. But ultimately, in the end, when we look about how the pelvic floor is functioning, it's all about our gait. It's all about how we walk and how we move. Because how your feet move and communicate with your bones in your legs and the muscles in your legs, which then communicates with your pelvic floor, is going to play a critical role in the health of the pelvic floor. And so, what I talked about earlier, I had everybody take their shoes off and your socks off. So, let's just do it again. Let's just do it again, everybody. For anybody who's new here, take your shoes off, take your socks off. So, this is written by Dr. Jerome Weiss. Dr. Jerome Weiss, who worked with chronic pelvic pain for 50 years before he retired last year. And the more holistic, no. He's a urologist who was just massively intrigued by the entire thing of chronic pain and why people weren't responding to chronic pain. And he points to some research. It's very interesting. One of the things that really changed his perspective was back in 1981. Was it 19? Yeah, 1981, when two researchers at UC San Francisco presented research that proved that patients with overactive bladder had spasming sphincter muscles, had spasming muscles. In fact, Dr. Richard Schmidt, who is kind of a dark figure in the IC world in some ways, was one of the doctors who really was able to first prove that overactive bladder appears to be triggered by muscle dysfunction and specifically by urethral sphincter muscles. And so Dr. Weiss, also in San Francisco, who ran the Center for Pelvic Pain in San Francisco, had this very evolutionary journey where he just, was extremely open-minded and was willing to read everything because he really wanted to help his patients. And one of the last things that he incorporated into his clinic was podiatry. Okay, so let's look at this picture for a moment. So here's your pelvis, right? So your pelvis is carrying all the weight from your abdomen as well as all the force. Sorry, I can't really hold this. I don't know how to hold this. All the force is coming up from your feet, right? So that's undeniable. And think about how big your hip bones are. The bigger the bone, the more weight it's meant to carry. The biggest bones in the human body are, in fact, the hip bones. And now let's look at this too. This is important. So what pulls it all together, right? What pulls it all together is we've got hip bones, and then we've got your sacrum, and your sacrum is the bottom of your spine. These are the sacral oh come on, discs, but they're all fused. They're fused together, and then the sacrum is attached to the hip bones by 3 ligaments. Okay, so you got 3 ligaments here, and it's these 3 ligaments that keep things, think about it as you're walking, one hip forward, one hip back, one hip forward, one hip back. And then if you open a leg to the left, open a leg to a right, it's really about the movement of these ligaments. And then above the ligaments, you've got a bowl of muscles, a bunch of different muscles that cover the base of the pelvis, but also the sides of the pelvis. The piriformis muscles go up the side. It's this bowl shape, right? It's not flat, it's a bowl shape. So when you walk, how did I do this before? Look, the weight goes directly up to the top of the femur into the base of the pelvis, where it is going to flex and or influence these ligaments and muscles. Now, if your ankles are doing this, if they're overpronating, or it's called supination, this directly creates dysfunction in your pelvic floor. The muscles are interesting. You're supposed to, when you step, your big toe is supposed to take 2/3 of the weight. Your second toe takes the next third, and your ankle kind of does. So the way you absorb rough surfaces is when you're stepping down. It's like a bag of bones. It's very responsive and it's not rigid. And that's called pronation. And then there comes this instantaneous point where you need to push off. And when you need to push off, everything gets stiff because it has to push you off the ground and lift you away. So the movement of the bones of the foot are fascinating. Um, if you're duck footed, you're outward turned, or you're pigeon toed, inward turned, if you have tight calf muscles, if you have weakness in your inner leg muscles, if you have asymmetrical legs, if you have a difference in leg length, this where you have one leg longer than the other, think about how your body would adjust to that. So what your feet would do, if we can do it side by side here, I wish I could do them both the same way. So here's your foot. We got one foot higher than the other, but they need to try to work together. So what happens is the longer leg flattens because it's trying to make itself as short as possible so it doesn't create imbalance. And then the shorter leg arches. And so you end up walking like this, flat arch, flat arch, flat arch. And that creates just tremendous strain and dysfunction of your fascia, your myofascial system throughout your entire body, but especially on your pelvic floor. But there's a doctor, Dr. Janet Travell, back in the 60s. She was one of the doctors for John F. Kennedy when he was president, is one of the most well known for understanding myofascial conditions. And they actually believe that foot dysfunction can lead to fibromyalgia, which of course is myofascial pain. And that it really literally begins with how we're walking and how our body is absorbing the strain of our gait and how that is being reflected up into the pelvis, right? So red flags a signal a problem. A bunion deformity on the great toe resulting from abnormal body mechanics can cause lower extremity problems. While bunions are sometimes identified in the pediatric population, in most cases they take decades to develop. In particular, pronation of the foot leads to instability of the great toe, which will result in the foot becoming wider and not fitting well. Number two, hammer toes, toes that curve down. They occur when individuals with overpronation gain foot stability by gripping on the surface with their toes. Over time, the toes will continue to curl and develop hardened areas. Number three, plantar fasciitis is pain in the arch or the heel of the foot, which is present on arising from bed in morning or from a seated position or with increased activity. It is usually the result of a low or flattened arch combined with a great deal of walking on hard surfaces, climbing stairs, or athletic activities. Shin splints. I've been diagnosed with all of those. It's hysterical. Normally, in the act of walking, when the foot is off the ground, these muscles are turned off and relaxed, while other muscles of the foot provide stability. However, with overpronation, the muscles of the feet cannot contribute to stability. Okay, so let's look at this. I want you to look at this picture. So look, here is a healthy leg, and here's an overpronated leg. And I want you to look at what it's doing up in the pelvis. So the overpronated leg is causing this hip to push out more, and it's stretching the piriformis muscle. And which is then weakening the piriformis muscle, which will then develop trigger points, which will then start pressing on nerves. And you have the piriformis, there's other muscles in there too. And when I I've had all this worsening pain sitting for the last decade, right? And I did all the physical therapy. Nothing fixed this pain in my left butt cheek, like on the inside of my sacrum or on the inside of my sit bone, like right next to my sacrum. And I went through Kaiser physical therapy and it didn't matter. Nothing fixed it. I mean, I'm really fit and really athletic and I couldn't fix it. Finally gave it up, went to an athletic trainer last year. He had me walk down the hallway several times and I was wearing leggings, right? And he goes, "Do you know when you walk, you curve?" And I went, "What do you mean?" He goes, "You walk like this." I was on my left side. My hip came out on my left side. So you're walking like this. Like, I don't know. Really? I can't feel it. He goes, oh yeah, it's very obvious. And look, this picture is explaining why. This picture is explaining exactly why that happens because his foot is messed up, right? So what I had everybody do is look at their feet. Is your second toe longer than your first toe? If it is, you have something called Morton's toe. And what that means is that you're not walking normally. Normally, when you walk, all of your weight lands on your big toe, or most of it. Your big toe takes 66% of the weight. When you got Morton's toe, that means your second toe is taking all of the weight, and it's not meant to take all of the weight, and it's creating hell up your legs and up into your pelvis. So there are a couple different signs, but you can still have, if you've got toes the same length, you can still have Morton's toe. And so let me show you a picture. It's all about a kind of a genetic, it's a genetic alteration. It's not something anybody controlled. It's not an injury. Hold on, I got to find it. So this book has a whole chapter on Morton's toe. It's like, holy hell, I wish I'd read this before. Okay, so look. So so this is your foot, right? And the only knuckles you can see are your toes right up here. You don't see, I mean, okay, like these are the big joints, and then the knuckles up there are your toes. This bone is supposed to be longer than this bone. If this bone is short, it is going to create chronic dysfunction in your feet and your pelvis. And they've known this for 60, 70 years. I mean, he's backed this up beautifully. Beautifully. Why the first metatarsal bone is important. The first metatarsal bone must be at least as long as the second metatarsal in order to work properly. When the bone is shorter, it can't do its job of absorbing the stress on the forefoot from walking, standing, and pushing. If the first metatarsal is shorter than the second and you take a step, the second metatarsal meets the ground first. This blocks the first metatarsal from doing its job, supporting the weight of the foot. And now it has completely stressed the bony structures in your feet, in your legs, and in your hips, which could lead to chronic pelvic floor dysfunction. So here's what it looked. Here, this is a better picture. Okay, so what do we look for? So we look for, now how come I could hold this? I was able to hold this before. Okay, so let's look at this picture. So this is kind of an exaggerated Morton's toe. So we're going to look for the bigger toe shorter than the second toe. We're also going to look for webbing. And I have this too, where between the second and third toe, it doesn't come down as much. And underneath it all, what you see is that this bone is short. This bone is supposed to be long, it's short. It's genetics. It's genetics. And that's why they've traced this back through families. And I think that that might be one reason why they trace IC through families. I haven't done this yet with my family. Oh, no, I did with my dad last night. My dad has Morton's toe. Totally has Morton's toe. And he's going through frequency urgency right now in this process. Right. Okay. So what are we going to look for? We're going to look for a visible change in the length, although they can be the same. We're going to look for this webbing. But the really the classic way to do it is okay. The third thing we're going to look for is something called hammer toe, which I have. So if you look at my second toe right here, it's bending down, right? On both of my feet, it's bending down. That's a sign that this toe is trying to grip the ground. So that's a sign that this toe is doing more work than it's supposed to be doing. It's ugly, isn't it? I mean, and I can push it back, I can straighten it out, but its natural position right now is bent down. So that's a sign that there's a problem there. But the most important thing you can do is if you just bend your toes down, look at the joints here. Look at those two joints. If this joint is lower than this joint, so you can see, look, I've got my fingers over it. This joint is probably a half an inch shorter than this joint. And see, you can see I've got the webbing. See, look, there's the webbing. And this is both of my feet. Look, you can see the hammer toe right there. It's kind of curving. And see, look, when I bend it down, I can't even, so the hammer toe on my left side is worse because my left side is worse. I mean, that's not surprising given the fact that most of my pain is on my left side, right? All right. Isn't that ugly? That's so ugly. Okay, but if you bend down and you look at that, you can see, now this one, not quite as bad, but this is still, so that knuckle is right here, this knuckle's right here. You know, maybe a little bit less than a half an inch, but it's enough to cause this hammer toe. Now, what's so interesting about Dr. Weiss in his practice when he actually started networking, you know, with a podiatrist or brought him all this stuff is that when he actually looked at his patient base, because he's one of the top pelvic pain doctors on the West Coast, 80 to 90% of his patients with chronic pelvic pain had Morton's toe. And what he found, and he just shares lots of case studies here, lots and lots of case studies, is that he would have patients where they would do physical therapy and the patient would get better, but eventually the patient got worse again. You know, it was just constant chronic dysfunction at some point in time, where the therapy might work, you know, for a week or a month, but eventually it'd come back, and so that caused him to go, well, why the hell are we struggling with constant chronic muscle tension? And what do we say? We always go back to bony structures. What's going on with bony structures? So we look at the hips to see if the hips are in balance. We look at the SI joint. We look at the length of your legs. But he started looking at the feet. And they were able to get patients into total remission when they finally corrected the feet too. So let me read a story here, okay? I read, this is Kevin's story. I will conclude this chapter with the story of a young man named Kevin who at the age of 18 had been suffering with rectal pain for half of his life. His history demonstrates how long-standing tension can lead to active trigger points, producing pain of such severity as to derail a bright future. Kevin had lifelong constipation with bowel movements every 2 days that required severe straining. When he was 9 years old, he developed urgency frequency, which was treated with behavioral therapy. At age 16, he experienced a brief period of extraordinary stress. Shortly thereafter, he woke up with rectal discomfort that he described as if someone stuck something in his anus, accompanied by incomplete evacuation of stool. All diagnostic tests were negative and no treatment was helpful. Extreme depression followed. Kevin isolated himself in his room and canceled his college enrollment plans. His behavior underscores the dramatic effect that pelvic pain has on the brain's emotional centers, where shoulder or back pain wouldn't elicit the same response. Remember that kind of primitive gut response. My examination revealed hypersensitive trigger points in the anal sphincter muscle for which he is now being treated. Based on his initial response, I am confident that internal manual therapy and anesthetic injection of the trigger points combined with stress reduction regime and psychological counseling to deal with what happened to him when he was a child can relieve his symptoms. It is very important that a significant emotional derailment be successfully addressed concurrent with his muscle treatment so that he may enroll in college and reclaim his life. The take home message: this chapter has given you some insights into the origins and inner workings of trigger points, as well as their potential systemic consequences. They lie at the core of chronic pelvic pain and dysfunction because they generally initiate a series of related physiological events, nerve irritation or damage, and central sensitization that can mushroom into a profoundly painful and emotionally distressing experience that is difficult to alleviate with you. It takes time for the trigger points. Okay, now that was supposed to be a foot story. What the heck? Sorry. Hold on. That was at the end of the foot chapter. Hold on. Oh no, I got it wrong. Hold on. Hold on. I got to give you another one. There's so many stories in this book. Hold on. Okay. Okay. Sorry, I gave you the wrong patient story. My bad. Okay, case number 1, a rear ender. Okay, so yeah, okay. A 56-year-old man was rear-ended while driving his car. Upon impact, his right foot was on the brake pedal. He experienced immediate right low back pain and pelvic pain when the impact transferred the force through his right leg up towards his pelvis. Pain developed in his right buttock, groin, and leg. The patient also felt pain with urination, penile erection, and orgasm. The mechanisms of this injury is one of a shearing motion to the pelvis that travels up the leg to the ischium, one of the 3 hip bone components, and the sacrotuberous ligament via the hamstring muscle. The sacrotuberous ligament connects the sacrum to the sit bone, and the hamstring attaches to the ligament. Yada yada. Our examination revealed dysfunctional pelvic floor muscles, an elevated right hip, and trigger points along the low back muscles and the iliac crest, which is your upper hip bone. Yada, yada, yada. The patient's symptoms were alleviated with pelvic floor physical therapy, osteopathic manipulation of the displaced hip, lumbar and sacroiliac joints, trigger point injections of the involved muscles, prolotherapy of the ligament, and a SI belt. Okay. Case number 2, a 37-year-old woman with a short leg. She had sudden unexpected onset pain in her buttock and leg that radiated down to her heels. She began having pubic and vaginal pain, urinary burning, and rectal spasm. These symptoms suggested lumbar disc herniation, urinary tract infection, hemorrhoids, and colitis, but all of these symptoms were ruled out with lab testing and an MRI. Dr. Weiss's internal physical exam revealed pelvic floor dysfunction. My internal examination disclosed a short leg, SI instability, SI laxicity, and a tender ligament. An x-ray of the patient's pelvis confirmed a short leg with a significant tilt at the base of the sacrum. A simple shoe lift and SI osteopathic manipulation combined with internal myofascial release to release the tight pelvic floor muscles relieved her symptoms. Case number 3, a 46-year-old fireman developed penile, perineal, and anal pain after lifting a heavy fire hose. Dr. Wise's examination and nerve testing revealed a pudendal nerve injury for which he administered pudendal nerve blocks and internal myofascial release. During this time, the patient had varying periods of relief, but unless he limited his activity, he experienced a flare. Concerned about the patient's limited progress and wondering if a biomechanical problem might explain it, he referred him to me. I found SI instability and performed a series of prolotherapy injections to tighten the SI ligaments, which solved the problem. A 50-year-old man has been seeing me occasionally for over 10 years. Over a 10-year period with an intermittent perineal pain. I had been treating his tight pelvic floor muscles and trigger points with internal therapy. Though he received great relief from these treatments, pain flares reoccurred. Frankly, I'd never completely understood the mechanics of his symptoms flares until he came in one day complaining of hip pain while walking over hiking trails. This led me to question him further and ultimately put us on the right track. I asked if there were any other musculoskeletal problems that he had not thought to mention previously. He responded that he had always had pain at the base of his large toes, which he attributed to arthritis. But because he knew that other family members had the same problem, he never sought the attention for this congenital issue. I then examined his feet, something I was not accustomed to doing, and found bunions and moderate overpronation. At that moment, the light went on. I had found the origin of his hip pain he had experienced during hiking, and also the intermittent perineal pain. Podiatric treatment of his feet eliminated his symptoms. Case number 2, another case. 65-year-old woman came to see me with a history of recurrent urinary urgency frequency and urethral pain without infection. Examinations revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual-therapy, to which she responded positively. However, she continued to have flares. While my treatments were effective in the short term, the results only endured for variable periods. At the time of her last visit, armed with new knowledge, I looked at her feet and noted unusually high arches. When I asked her if she had experienced any of the potential side effects of such apparent abnormality, she came out with bilateral Achilles tendonitis, knee surgery, and hip pain. In my mind, I visualized a straight line of mechanical stresses. It began with a foot imbalance, which affected the tendons, then the knees, then the hips, and ultimately the pelvic floor. A visit to the podiatrist was the last stop on her healing journey, and it is unlikely that she will require any more pelvic floor sessions. Interesting. 42-year-old man with voiding difficulty reported that at the age of 14, he had severely fractured his left foot, leaving him with a short leg. Since that time, he had assumed many abnormal positions when sitting to protect the leg. Within a year or so of this injury, the voiding difficulty began, and he was too embarrassed to mention the problem to his parents till another year passed. He was subsequently found to have tightness of the pelvic floor muscles, which is typical of voiding problems, and had limited success with manual therapy and biofeedback administered by another practitioner. When I examined him, the short leg was apparent, as well as externally rotated legs and severe pronation. A visit to the podiatrist was a missing link. Last but not least, a 31-year-old woman came to me complaining of vaginal pain during sex. The symptom was completely alleviated with manual therapy for tight pelvic floor muscles and trigger points. However, the patient then began to notice vulvar pain when she exercised, which I surmised had been there all along, but was masked by the predominating vaginal discomfort. Not infrequently, localized pain responses present themselves in the order of magnitude. Only when the initial discomfort clears will the patient become aware of subsidiary distress. Ongoing diagnosis is required, and the course of treatment is rather like peeling an onion, removing one leg at a time, removing one layer at a time. When I examined this young woman, I found nothing in the vicinity of her pelvis that would explain her vulvar discomfort. However, this time I scrutinized the extremities for clues to her new symptoms and noted extremely high arches, which were no doubt the cause of her previously noted hip rotators. I referred her to podiatry, who fitted her with orthotics, and her pelvic pain disappeared. This was one of the cases that led me to realize the importance of a routine biomechanical assessment at the time of the intake exam. Now, the cool thing about Morton's toe is that you can fix it easily. $2. And they explain how to do it. It's just basically a foam pad that you stick to this big knuckle so that this knuckle will absorb the weight of your body before the middle toe. And you can get this book on Amazon. I am not paid to do this. I receive no money for anything. This book is changing my life. I think it's amazing and brilliant, and I think you need to get it. You need to read it twice, 3 times, study it. And then, armed with this book, better yet, get 2 books, go back to your doctor, give them the book, show them the chapters that you think relate to you, and it's time to start to ask for some new exams. And a referral to a podiatrist. Why the hell not? Hey, man, you got nothing to lose but pain. Go for it. All right. Let's go back to your questions. Patricia says, I appreciate the work you do. Several years ago, you coached me through a phone appointment. You confirmed, understood, and identified what was going on. Whereas the urologist I had at the time wanted me on home health and hospice. I learned a lot from you and your site. I relocated, found a great urologist. I'm the best me I can be. Yeah. Patricia, woohoo! I love success stories. Hey, man, Patricia's story should tell every single one of you, do not give up. If it's not working, if bladder therapies aren't working, it's time to take a step back and let's consider the pelvis. It could be something as simple as your freaking big toe. Prolotherapy. Prolotherapy is when they inject a very simple sugar solution into a weak ligament. Very benign, is nothing caustic. There's not a medication, it's just a sugar solution. But what that does is that provokes a healing response that will strengthen that ligament. It's called prolotherapy. Prolotherapy. So if you've got SI dysfunction like I do on your left side, then that would explain it. Ravonda says, went to have my eyes checked. I was the second person that morning that brought up Elmiron and retinal damage. She had read a 20-page report on it. The word is getting out. Your eyes are fine. Awesome sauce. Good, good, good. I'm glad, hun. At least you don't have to worry about it. But I mean, we've certainly learned a very painful lesson with Elmiron and eye disease. Sue, did you find any foot pads that have adhesive on the bottom so they will stick to your shoes? Yeah, I got the oh damn it. Here, hold on. I always forget the name of it. I'll go get it. You know, it's just so interesting because now as I'm walking and I'm paying attention to my feet, I can totally feel that my big I can totally feel that my big toe is not carrying its share. Moleskin. Moleskin. The problem with the moleskin is it's very, very thin. This is what I started with. And so what I'm going to do is I'm probably going to do 3 or 4 layers of moleskin, and they have a sticky back, and I'll try that one first. I'm playing with it too. I have a podiatrist. I have orthotics because I was diagnosed with Morton's neuroma. So I have orthotics in my Uggs. I cannot wear any flat shoes at all. And wearing Uggs for more than an hour or two, my feet will start screaming. So I've got orthotics in there. I don't have orthotics in my other shoes. And I want to go back now to the podiatrist and talk to him about it a little bit more. Anna says, I find that ACT products and Colgate Hydrous work better than Biotine products, but I have severe dry mouth and not Sjogren syndrome. Yeah, I have a Sika myself, which is a variant. Yeah, I just bought the gum. I really like it, but I have TMJ, so I chewed the gum for about 15 minutes and then I stopped. Ravana used 6-day prednisone taper to try to break the daily micro and cause bladder pain. I don't know. You have to Google it. Molly says, you keep getting kicked out of the stream. I have no idea why, hun. It's not me. Catherine says, the sacrum is truly the core of our stability. I know, and I just, honestly, I just really hadn't thought of it like that. You guys got to remember too, the second football game is going to be starting soon, and so Julie says osteopathic doctors practice their skills. They believe that every tissue in the body is connected to the whole body. Teresa says, I have pronation and always wondered if they were related. Yeah, I think they're related. Jolene says, had a knee injury, sure change your walking. Yeah. I know, Julie. Julie says, I have Hunter's ulcers, but also bladder wall and pelvic floor issues, everything, including SI joint. I know. Isn't that crazy? I mean, this book is such a gift. It is such a freaking gift to us. We have come so far. And some of the case stories that he shows in the book are just chilling. I mean, patients who, have had pain for 30 years, 40 years, who have tried every therapy, who were considering one patient I think was considering, oh, look, I did it again. I just tried to put my foot up on my chair, which you're not supposed to do. Oh my God. See, personal habits. It's crazy. Anyway, so this was a patient who was considering bladder removal, and before she went to bladder removal, she went to Dr. Weiss, and he diagnosed her with, really massive trigger points and was able to fix her, and she didn't need her bladder removed at all. Leela says, which Hoka shoe collection for women are the best for pelvic issue gait? I see. well, right now, so I have two. I have the Arahis, and I have the Bondis, and I'm wearing the Bondis right now. So I was doing really well with the Arahis. Here, let me get a pair of them. I mean, when you're all younger and you're trying to dress and look sexy and you wear your high heels and all that sort of stuff. It's amazing how none of that matters when you're a certain age. I don't wear high heels anymore. I don't do anything like that. I like literally wear yoga pants every single day and hokas, just about, or Uggs with my orthotics. So this is a Arahi, and I did really well with these for 2 years. I just found these shoes. These are called hoka11.com. These are highly recommended because they can help with pronation. They can help with all sorts of stuff. And they have several different varieties, and they have several different cushioning levels. So this is a medium cushion, um, and absolutely love these. But I was still having trouble walking, and so and in my brain, I always go back to the shoes I wore for a long time, which were Birkenstocks. I love my Birkenstocks when I was in college. And I know I can't wear Birkenstocks because they're just too hard, but the SAS shoe store, which I call the old lady shoe store, which my mom wears in her 90s, had kind of a bigger Birkenstock. And I thought, you know what? Oh my God, I'm going to go to SAS. I'm going to try it, right? This was like 2 months ago. And so I bought a pair of shoes, brought them home. Within an hour, my feet were screaming, screaming. So those went back, got my money back, and I couldn't even wear these shoes. There just wasn't enough cushioning. So then I bought the Hoka with the most cushioning, which is the Bondis. And I have been living in these, and they are fabulous. And what I did, I can walk around the block. I mean, I can do long walks usually. Walking around the block here is a long, walking around the block here is a mile. So, um, so what I did is I've just started putting the cushioning here underneath that big toe, and you can see on this insert, like you can see my toe reflection, right? So here's my big toe, which is shorter, obviously, than my little toe in terms of the knuckles. Absolutely fascinating. So I'm excited. I really want to see if correcting this foot issue is going to help resolve my SI issue, which hopefully will also help resolve my TMJ issue because they say it's all connected. John says, is it best to avoid lidocaine and compounding meds due to possible irritation? I've been dealing with vulvodynia now, as well as UTI. So John, you must be the wife of John. I am yeah. Okay. I am postmenopausal with tight pelvic floor muscles and urethral spasms. Is it best to avoid lidocaine and compounding meds due to no, no. I mean, it all depends upon if it hurts or not. I mean, I used lidocaine and estrogen and Vaseline jelly. It was fabulous, and it took about a couple weeks to a month for a lot of that vulvodynia pain to completely go away. And but ultimately in the end, the question is why were my nerves compromised in the first place? And the answer went back. What the pelvic pain specialist said, she thought it all went back to my hysterectomy 2 years ago, where I had a lot of involuntary muscle spasms, and she thought that my muscles were again compromising a nerve that was triggering the vulvodynia. So the therapy was two pronged. Number one, the lidocaine to silence the nerve and get the nerve calmed down, and then the pelvic floor physical therapy to stop whatever muscle was compressing that nerve in the first place. And so that's what we did. We did the lidocaine, estrogen, and then we also did the physical therapy. And they were both equally important. And I just had my last appointment with her, and I hated saying goodbye because you know, I want to always have somebody there if something happens. Anna, is there any help? Oh my God, girl. Absolutely. That's the entire point of this meeting. Is there's tremendous hope here. Tremendous hope. And this is giving us another avenue to explore. If you have constant chronic pain in your pelvis, if you've got tight pelvic floor muscles, if your bladder symptoms are not responding to bladder therapy, we have to look beyond the bladder. We got to look at the muscles. And more importantly, we've got to look at the biomechanics of your body as a whole, because your pelvis plays the critical anchor role in the body. It is going to feel damage up below, up above, and below. So if you break a rib and a muscle gets tied up there, your pelvis is going to be tweaked that way. If you break a knee, you have a hip replacement, or you don't walk correctly because you've got Morton's toe, that is absolutely going to influence your pelvic floor and potentially present you with chronic pelvic floor dysfunction. Tight muscles, that's going to lead to trigger points. Those trigger points might be latent at first, which means they're silent, but then eventually it persists so long, something happens that turns them on, and bam, you've got frequency, urgency, pressure, pain. And if you have pain with sitting, then we're going to look at nerve compromising. It means those muscles are so tight, they might be squeezing nerves. Nerves get compressed. And this book has a beautiful picture of a compressed nerve. I hadn't really, kind of chilling actually. So look at this. This is a healthy nerve. So a healthy nerve is actually round, and actually inside of it, I don't know if you can see this, there are actually several different nerve fibers. So it's like an outer tube with a bunch of inner tubes inside of it. Inner tubules inside of it. So you've got afferent nerves, you've got efferent nerves, there's lots of structures. So there's blood vessels in there that is supporting this healthy nerve function. If that nerve is compressed by a muscle or a ligament, it flattens. So the first thing that happens is the little microscopic blood vessels in that nerve burst, and they let blood flow into this tight space, and it puts more pressure on the nerve. Then the nerves get damaged. The blood vessels leak plasma, creating pressure within the closed compartments. Then whenever it gets compressed like this, what happens is that the myelin sheath gets injured, and it leaves open areas where the nerve is directly accessible. So I've worked with some patients who feel like they have a shocking sensation, like their whole body is getting shocked. And he describes that, and that usually happens when a nerve is directly exposed. It's lost its myelin sheath. It's lost its nice connective tissue protection right there. Okay. Then any trapped fluid compresses the fibers, creating inflammation and scar tissue, right? So there's deep inflammation in this flattened nerve. It damages fibroblasts. The fibroblasts release myelin damaging substances, and you get this vicious circle of damage. Obviously, this is not going to be a healthy nerve. This is a healthy nerve. This is what happens with chronic muscle tension. So this, they believe, is underneath driving a lot of vulvodynia. Vulvodynia isn't just about estrogen atrophy. Vulvodynia can be caused by muscles that are very, very tight. And so it's an incredibly good book with lots of patient stories and lots of therapies, lots of things you can do. Rhonda says, what causes bladder incontinence? Weak muscles, weak pelvic floor muscles. You've been trying to do pelvic physical therapy to strengthen your core, but Kegels, IC doctor says not to do Kegels. Not sure if this started when doing physical therapy core exercise or when you took prednisone around the same time. No longer doing the core exercises or taking prednisone post menopause. You're gonna have to talk with a physical therapist to have another proper pelvic floor physical therapy. Therapy session to figure out, or a diagnostic evaluation to see if they can narrow it down a little bit more. Again, if you've got chronic weak muscles, that still could potentially go back to your feet. It could. That's why, again, physical therapists normally have you walk up and down a hallway to see how you're walking. John Lee, I have a neuromuscular disease that affects my skeletal system, have pelvic bladder issues. I feel completely overwhelmed. I mean, where do you start? I've been treated for so many things separately. We need to be looked at as a whole. Maybe an osteopath, Loretta, maybe an osteopath who will deliberately look at the entire body rather than pieces. Cynthia says, do you prefer, which style do I prefer? I like the Bondies. The Bondi 6s, I think, are the ones I'm using right now. Not the Bondi, the Bondi Classic that they just reissued that was a white and yellow shoe. I actually ordered those and I hated them and I turned them back. The new Bondi 6s. Susanna says, wait, Elmiron and eye disease, what's the link? In 2018, eye researchers at the Emory Eye Center in Atlanta, Georgia, published a paper in which they believed that they had found a new eye disease associated with the use of Elmiron. And essentially, what was happening was the cells in the retina were changing color. It's called pigmentary maculopathy. The symptoms were blurred vision, difficulty going from high into low lights, or going from highlight to low light, blind spots, things like that. So we've known this now for a year and a half. Of course, the challenge here is urologists don't read eye journals, and it was published in an eye journal. And so, what those urologists at Emory did is they sent a letter to the editor to the Journal of Urology in the spring of 2018, in which they claimed that they believed that they had found a new eye disease associated with Elmiron use. And I actually have all of those articles. So it was Labor Day. I was in the National Library of Medicine because I'm a geek and I like reading about IC, and I was looking for stories on IC, and I found a reference for this obscure letter to the editor. And so I logged on to the Journal of Urology website and read the letter and was like reading this going, oh shit, oh shit, oh shit, oh, this is bad. Stunning, stunning. And I have the paper here. This is really important, guys. I mean, this is another, think about it. If imagine all the useless prescriptions for Elmiron, if for those patients whose symptoms ultimately and fundamentally were muscle issues. It's just stunning. All right, so here's the letter to the editor. Not that you need to read that. So this is the journal article they published in Ophthalmology, their first publication. And it was what we call a case series. The purpose of the article was to show in 6 different patients that this eye damage was happening. This was not making any statements about population data. It was just making the case that, hey, we're seeing this. Okay. And so let me show you the pictures. So these are pictures over time, and I think that this is probably the best picture. So this was the first visit, this was the second visit, and this was the third visit. And you can see here, first visit, second visit, third visit, same here. One small white spot, multiple white spots, and now look, we got a lot of white spots here. And I think the picture that's this is also, you know, so again, kind of a same series. You're starting out with some, I mean, you can just see that they're getting bigger and more connected, right? So they believed, and I think that this is probably one of the most important pictures because this is a side view of the retina, and you can see in the retinal cells these white spots, right, which is showing that these retinal cells are changing color, and something's happening with those retinal cells. So I read this article and was like, oh shit, oh shit, oh shit, oh my God, oh my God, oh my God, is this real? This is terrible. How are we going to tell IC patients about this? And I'm like literally sitting at this desk crying. You watch my first video on it, totally crying the whole time. This is terrible, terrible news. So I emailed our medical board and I said, guys, have you seen this paper? Two of them already had. And I said, let me do a survey of our members and let's credibility check the data. So I threw out a quick survey, sent out the first article about it to about 35,000 people and 35,000 diagnosed IC patients. And today I have about 1,700 people who have filled out that survey, who have taken Elmiron, and 54%, 54% in our study, in our survey, report retinal disease, which is a staggering number. I sent my data to the chairman of the American Urology Association IC division. He was stunned. He asked me to send it to the FDA to request a labeling change, requesting eye examinations every year. Since that time, ophthalmologists around the country have now documented that they are also seeing this in Elmiron users. The first population clinical based study was done here in Northern California. It was published last November. It was an ophthalmologist at Kaiser Permanente in Oakland who was so intrigued by the initial data. He went back into his clinical database. He found 140 patients who had used Elmiron, who were currently using Elmiron and had used it for at least 5 years. Out of those 140, 91% agreed to come in and have their eyes examined. 24% showed eye damage. So that's our first clinical data, 24% of this population. But again, there were 50 who didn't come in. And so, and we had a nationwide study. So now there's no doubt this is real. There's absolutely no doubt this is real. This is a big deal for the IC world. This is a great tragedy. And in fact, the first patient who called me after I sent out that first article was crying on the phone and she goes, oh my God, you just prevented me from going blind." And I went, "What do you mean?" She goes, "We couldn't figure out why my eyesight was getting so bad. They'd ruled everything else out." She took the article to her ophthalmologist. She was diagnosed with this. So, and in fact, one of the patients in this study, now one of the things this study said is they thought it was associated with long-term use. However, in this first paper, the patient who had only used it for 6 years actually had the worst damage. So you're going to see some discussion about long-term use, but understand that when you actually look at the papers themselves, patients who've used it for small periods of time have also experienced eye issues. So when this paper came out, and these ophthalmologists were trying to figure out what the hell's going on. They did their due diligence. They went back to one of the early clinical trials that led to Elmiron's approval by the FDA as a drug. And in this study of 2,499 patients who took it up to 4 years, eye issues were noted. Retinal hemorrhaging were noticed. Amblyopia was noted. There were several things that were noticed, eye symptoms that were noticed in that first study. And yet, if you look at all of the Elmiron patient education materials, other than the drug fact sheets or the brochures and the handouts, none of them mention eye issues, which is why I think we're going to see litigation sooner rather than later. The key issue now is, and I had a patient call me Friday crying because she'd just been diagnosed with it, and she wanted to know if it would ever go away. And my answer was, we don't know. But we now have our first case study, which shows that it's progressive. It was progressive in at least one patient who stopped the medication. So this was a patient, this was an ophthalmologist at Harvard. So again, impeccable sources, right? So an ophthalmologist at Harvard had been working with a woman for 10 years. The first time she came in, she was 61, 62 years old, had bad issues in one eye. And then the process of that examination, they actually thought it was a toxic exposure of some type, a toxic maculopathy, but they couldn't correlate it with any exposure. So they kind of ruled that out. Patient came back 6 years later. The eye damage was now in both eyes. Patient came back 2 years after that, was much, much worse. And the problem is that she had stopped the Elmiron 7 years earlier or 6 years earlier. And so this is what the doctor in the first letter to the editor was worried about. They did not know if this was progressive. And now we have our first case study showing that at least in one patient, it was progressive, or it is progressive. And they correlated this with a medication called Plaquenil. Plaquenil is also known to cause progressive eye damage when the medication is stopped. But there is some good news there in that eventually, after a couple of years, the Plaquenil apparently goes out of the eyes and that patient's eyesight recovers. And so there's a hope now that maybe that same thing will happen with Elmiron, that hopefully over time, if this is the medication itself accumulating on the eye, that perhaps with time, um, it will eventually leave the eye. It will somehow be broken down by the human body. So we're now telling anybody who's using Elmiron, especially if you're experiencing any changes in your vision, to go have a retinal exam immediately and to stop the medication immediately. And that's straight not only from the eye researchers, but the IC specialists who are working with them. That if you're showing, because urologists don't check for vision, just like they don't check for foot dysfunction, right? And so it's something that we really have to be on top of now. Hello, Matthew. And the name of the book author is Dr. Jerome Weiss, as Janice just said. Susanna, I'm on Elmiron. I've been on since 2007. I'm being checked for glaucoma. Do you know if it causes glaucoma? Susanna, you need to come on over to our website, and you'll see right on the front page a link to our article on it. And I've got a downloadable fact sheet you can take to your doctor, and you absolutely need to be checked for that. It caused a wide variety of symptoms, a wide variety of issues. So you absolutely, since you've been on Elmiron for 12 years, you've got to get checked for this pigmentary maculopathy. Emily says, I was thrown from a car at 15. I had to have nerve graft surgery, and right after that graft and allergy reaction to the NSAID, the nightmare began. Also startled a cabinet at age 5, but these IC symptoms did not start until after the nerve graft surgery. Well, Emily, ultimately in the end, you suffered a major trauma, and that's what they see with these types of issues is a triggering event, a triggering trauma. You were thrown from a car. So you're now like the third patient I've worked with. I've worked with 2 patients who were run over by cars, one by a truck, one by a car, and who had their pelvises impacted and in one case crushed. And the damage that did to their pelvis as they've gotten older is really profound. So, I mean, it's going to be very interesting to see how you're walking, to see if that affected your walking, how it affected your movement. And if that is in any way triggering any bony dysfunction in your pelvis, it could then be driving your bladder symptoms. Anna says the drug has made people blind. I've never worked with any patient who's gone totally blind with Elmiron, but it's moving towards blindness in some patients. Anna says your Hokas remind me of the original. I don't think so, hon, because the Skechers never had good padding. The Hokas have massive padding. Cynthia says for dry mouth, Xylamelts lozenges by Orco. I used to use Xylamelts really frequently. My dry mouth has been much better. It's just I'm talking a lot now, so my mouth gets drier. The problem with xylitol, and they all have xylitol in them pretty much, is your body can only take a certain amount of xylitol before it starts flushing it out, and it flushes it out in the form of diarrhea. And so the problem with dry mouth gum is if you chew a lot of gum every day, you're going to end up with diarrhea from the xylitol toxicity or the it's not toxicity, xylitol, I don't know, breakdown. So you got to be careful with xylomelts. I have them here on my shelf here, but I haven't had one in my mouth in a decade. In fact, I think I threw them away. I'm just going to say right now here, allow me to vent a little bit. I am stunned that we're not seeing any other IC group talk about the Elmiron eye issue. It's like I'm the only voice, the only national voice talking about this. And I think it's absolutely disgraceful. Every IC group out there should be educating patients now about this Elmiron eye issues. Studies are the valid research studies from Emory and from Harvard, along with clinicians around the world. I was told at the ophthalmology meeting in 2019, every ophthalmologist attending the meeting said when they surveyed them that they were treating Elmiron patients. So this is big. So please help us save the eyesight of other patients and let people know about this. Let's go down to YouTube here for a moment. Becky's asking about the homeopathic medicine. He only mentioned two. One was arnica, and the other one was, I don't know if I can find it. You know what? You'll just get the book. You see, I'm writing my own book in response to this book. I mean, for me to reference to. I'm looking for it. Here it is. You can't treat the problem successfully if you don't know what it is. Medical schools don't treat myofascial and pudendal nerve pain. Physicians only work with the tools they are given. You must look beyond the obvious. Though pelvic floor dysfunction and PNE is more recognized, therapy is often not comprehensive enough. There are also biomechanical, nutritional, and or emotional components that must be addressed. If it's not treated early, central sensitization can develop. Every patient receives individualized therapy of bony structures, muscles, organs, tissue, skin, nutritional deficiencies, hormone imbalances, and emotional state. Oh, I don't see it. It's in here somewhere, but I know the first one was arnica. Okay. I don't know what you mean by blaster. Oh, it's a tool for for massaging fascia. It's marketed mainly for cellulite, but its original purpose was help with. I don't know anything about it. I'm sorry. I mean, you got to be. I mean, the only time that makes sense. Again, you've got to read the book because it's not just fascia; it's muscle, and it can be ligaments, and it can be nerves, and it could be skin. And so you can't just put all your money in one treatment approach, right? Iris says, could it be a nerve chronic pubic pain with burning and throbbing? Yes, but it also, the six pack muscles, right? The muscles that make that nice six pack that we like, that, people kind of like, that actually attaches to the top of the pubic bone. And so that could actually be trigger points in that specific muscle, the muscle that gives you your trigger points, which is the rectus abdominis. It runs down the abdominal wall, then attaches to the pubic bones and some ribs. With trigger points, they can cause lower abdominal, pubic pain, and urinary symptoms. Also, there is a line of tissue. So you've got two different lines that go down each side, right? And they're connected. They're connected by fibrous tissue called the linea alba. And if it can't maintain the integrity, it separates and the organs lose their support, fall downward, and increase pressure, also known as diastasis recti. And that happens in one third of pregnant patients. So here for subcutaneous tissue restriction, just below the skin is a layer of fat, connective tissue, blood vessels, and nerves that regulate skin and body temperature. When healthy, this is elastic. When it's dysfunctional, it loses elasticity, restricts blood flow, causes nerves, visceral, and muscle irritation. If skin over a sore type muscle is usually sensitive, skin may thicken and develop an orange peel-like appearance. An overactive SNS. So the subcutaneous treatment is manual technique of connective tissue manipulation. It doesn't work. If it doesn't work, an anesthetic infiltration of tissue may be used. It is extremely effective in IC and pudendal nerve entrapment. So your blaster apparently targets that same group of tissue, but he doesn't talk about it, and I don't have any experience in it. Hendria says, has anybody tried bladder rest? We've had, I think a couple thousand people do bladder rest. Did you have a question about it, Hendria? All right, let's go back to Facebook. I'm moving windows around. Who do you go to for trigger point therapy? That's usually going to be a physical therapist. They can do dry needling, but if they need to do if they anesthetize it because it's too painful, then you usually bring an MD into the room. Kat says, while watching this, I've sent a message to your doctor for referral to a podiatrist. Awesome. Please let us know what they say. Iris says, could it be a nerve, chronic pubic pain with burning and throbbing? Yeah, it could be a nerve, or it could be a trigger point in your rectus abdomini muscle. All right, hold on a sec. Okay, that's YouTube. Hold on, Facebook. I know I'm back on Facebook. Julie says, I will be buying this book ASAP. Thank you. Yeah, I mean, honestly, it's amazing. Okay, Leanne, do you have any resources for chronic kidney flank pain, neuroblockers, and I don't get along well, but my kidney spasms and constant nerve burn has gotten so intense over the last 2 years. I'm at my wit's end. Ureter implantation in 95 and other abdominal surgeries have them blaming past trauma, but only relief I found is medicating myself beyond the point of functioning. I have many other pelvic floor and IC related symptoms, but it seems I have a hard time trying to find info support and people who understand kidney pain. Leanne, there comes a time when a patient's case gets so complex that you really need to work with a national specialist. And I think it would be completely reasonable and important for you to work with somebody like Robert Evans at Wake Forest University, Ken Peters at Beaumont Hospital, Rob Moldwin up in Long Island, and get an expert's review of your body, because we're only guessing, and frankly you deserve more than a guess here. You deserve the facts. And so the question is a nerve burn that you're getting, why is that happening? Is it happening because you've got a scar tissue from a surgery pushing on that nerve, or is it happening because you're in so much pain, your pelvic floor muscles are tight and they're pushing on that nerve? And so, I mean, with the other doctors saying it's past trauma, that's absolutely reasonable. He talks in this book about past surgeries causing issues like this, especially nerve issues. And but it's more than that. It's not only, it's like, okay, you've got nerve pain, but why? Is it because you've got trigger points in those muscles? If you do, that's fixable, that's workable. Leanne, you need to buy this book so that you really understand the connection between treating muscles and treating nerves to try to help stop the nerve pain that you're having. I think it would only help you and give you ammunition as you seek more care. And I'm so sorry that you've been going through this. That is brutal. I was curious as to why you had to have your ureter reimplanted. Were you in a car accident or something? John Loretta says, "Thank you for this fabulous, although overwhelming session today." You imagine how I felt this last week. I mean, like painstakingly yesterday. I studied for 6 hours yesterday to try to get ready for this. And all week, every day for like 2 hours or so, I was reading different chapters of this book because I really want to absorb it and understand it so that I can pass it along to you so that you can explore these. Reading this and going, okay, look at your feet. Do you have this? Yeah. Wait. I've been I've been diagnosed with Morton's neuroma. I've been diagnosed with plantar fasciitis. I've got a hammer toe. What else do I need to know that my feet are not are probably a huge part of why I have this chronic pelvic pain on my left side. It's just so good. Sherry said, "Now, Sherry, I didn't know this. It's a fabulous book from Amazon. Did you all know that if you're disabled, you can get Amazon Prime at a monthly discount of $5.99? Holy crap! I had no idea. Thank you for sharing that. That's fabulous." Don says, "I shared the info you shared with us with my eye doctor. He read it and said he'd be watching for damage from Elmiron. And those that mentioned they've taken it. Luckily, he said in the past 2 checkups, my eyes are good. Good, but Don, keep having your eyes checked." Ravonda says, "I have connective tissue disease where my body makes faulty collagen all over my body, causes loose ligaments and joints all over, which then cause more muscles to spasm and weaken." And yeah, Ravonda, you're in a very, very difficult situation, hon. I get it. One thing at a time. Sometimes you just have to do one day at a time, 1 week at a time. He talks about how important it is to fight. Like one of the other things that I find is so interesting in my case, right? Um, Now remember, in all of my testing, my bladder's been normal. In all of my testing, my bladder for my entire life, my bladder has been normal. Starting in 7th grade when I had frequency urgency, they never found a problem with my bladder. And it's just mind blowing that Western medicine fails so badly with pelvic issues because doctors are just not taught about the interrelationships well enough to understand how different structures influence different things. And just the somatovisceral and the visceral somatic connection. And what that means is how muscles can communicate to organs and how organs can communicate dysfunction to muscles is so important. So remember what he says in his book is his theory is that for many IC patients, it begins with chronic muscle tension that leads to trigger points, which leads to nerve dysfunction. At the spinal cord, the constant chronic pain from the muscles overwhelms the nerves at the spinal cord and it cannot send it all up to the brain. So what happened is that those nerve communications. What word am I looking for here? Um, Neurotransmitters. So there's a spillover. So you've got this firing muscle group, just firing at the spine. Help me, help me, help me. I'm in pain, I'm in pain, I'm in pain. And the nerves of the spinal cord are overwhelmed. It cannot send it all up to the brain. So what happens is it goes right back down the other nerves that are in that same location, specifically to the bladder. So all the nerves in the pelvis merge at usually around L5, right? I mean, a lot of them merge at L5, but also down in the sacrum. And so the theory here is that wherever that dysfunctional nerve enters the spinal cord, every other nerve at that area becomes dysfunctional. So anyway, so here we've got this massive firing from the muscles going to the spinal cord. You get spillover right back down into the bladder. it triggers neuroinflammation in the bladder. That triggers the nerves to release substance P, which then causes the bladder wall to break down. And then that then triggers degranulation of the mast cells, which releases histamine, which releases more substance P. And then you see a breakdown of the bladder wall. But ultimately, the cause of that is, in fact, for many patients, long-term chronic muscle dysfunction, irritating nerves. So he really makes the perfect case for the chicken and the egg dilemma. Which comes first, the bladder, the pelvic floor? And what he's arguing is really it's the pelvic floor that is probably underlying the great majority of patients. And yes, we have subtypes. And yes, chemotherapy patients get this. And yes, chemical injury gets this. And yes, genital urinary syndrome of menopause gets this. Yes, 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 there are subtypes. But we cannot deny the structural reality, the biomechanical reality of how the pelvis is built, how it interacts with the organs, how it interacts with the upper back, the lower back, and the legs and the feet. And if your feet are screwed up, your legs are screwed up. And if your legs are screwed up, your pelvis is screwed up. And that is why in his clinic, ultimately in the end, what they for the patients who were not getting completely better, they went back and they looked at their feet and they found the ultimate problem in their feet. And so fixing the feet so your gait is normal, so that your legs are normal, so that your pelvis isn't stressed by abnormal legs and your fascia and your muscles is critical here. Myofascial. Renee says, I've been in Elmiron since 2000 at 400 milligrams. I've been to a retinal doctor and your eyesight is very bad, but you do not know how to live with Elmiron. Well, Hunt, there are a lot of things that you can use in addition to Elmiron. Elmiron has a bladder coating effect. So if you want to stick with Elmiron, switch from oral Elmiron to an Elmiron bladder installation, where they just put the Elmiron directly in your bladder with lidocaine. That dramatically reduces systemic absorption. It usually stays in the bladder and will not affect your eyesight. So that's concept number one. If you want to stick with Elmiron, the problem with, Elmiron, okay, Renee, think about it this way. If you swallowed a Band-Aid, would it come out the other end of Band-Aid? And the answer is no, we have digestion. And in pharmaceutical terms, it's called bioavailability, how much the medication arrives at the bladder where it can be helpful. And the bioavailability for Elmiron is terrible because most of it, more than 90% of it, some argue 95% of Elmiron is destroyed by digestion. So only if we use that number, and I've heard anywhere from 8% to 3%, but let's just use 5%. If that's true, that only 5% of the Elmiron actually arrives in your bladder to be helpful, that explains why you have to take a lot of it to get a meaningful coating, because ultimately in the end, Elmiron is a chemical coating. Now, at the European Society for the Study of IC meeting just 2 months ago, they talked about supplementation, and they specifically talked about chondroitin. That chondroitin has a similar bladder coating effect. And so, this has been going on. I mean, patients have been getting off of Elmiron for the last decade. Usually because they either have side effects. Elmiron is a rough medication to take because you have to take a lot of it and it's really prone to side effects. Gut distress, diarrhea, easy bruising, changes in liver enzyme level. So the first shot against Elmiron is the side effects. It's a rough medication on the body. And now, of course, we know the eyes. The second thing that has gone against Elmiron in the last 10 years is the fact that the price has skyrocketed and most people cannot afford Elmiron. If it's not covered by your insurance and it's costing $1,500 a month or every 2 months, it's completely unaffordable. I cannot afford that myself. And so at the 2006 IC conference in San Diego, we had there are two doctors on the stage, Dr. Lowell Parsons and Dr. Theo Theoharides. Lowell Parsons is the guy who invented Elmiron. Dr. Theoharides is the guy who invented Sister Protect. And a member in the audience asked Dr. Parsons, will I have to take Elmiron for the rest of my life? And he said, no. You just have to figure out if it's helping you. And they went, how do you do that? He said, you reduce the dose. So if you take 400 milligrams a day, well, he said go down to 300 milligrams a day for a week and see if your symptoms change. If they don't change, go down to 200 milligrams per week. See if they change. If you get worse, then we know a coating is helping you. If they don't get worse, he said go down to one a day. Do your symptoms change? If they don't, get off of it. See if your symptoms change. There's no tolerance with Elmiron. You don't have to worry about that. I mean, in terms of medications that are fairly easy to get off of, it doesn't cause drug tolerance like other medications. Okay, so that's from the horse's mouth. That's from the guy who invented Elmiron. Now, you know what? He might have said that. He did a lecture on our website. He might not have said that in a lecture on our website rather than the conference, but he was there. But at the conference, we had Dr. Theoharides, and Dr. Theoharides is the guy who created the most popular supplement for IC at the time, called Cystoprotec. So this is 2006, 13 years ago. So Dr. Theoharides is a peer of Dr. Parsons, but he's a nerd's nerd. He's a pharmacologist. He's a doctor, but he teaches at the medical school at Tufts University, and he's a keen scientist. He's like my brother, who's a keen scientist. He's they just love diving into the research. That's what makes them happy. And he was asked by the state of Massachusetts if he would investigate the safety of food supplements. And he went, sure, as part of his work at Tufts. So here he's doing this research on food supplements. Now, knowing he's already working with IC, he was the guy that I think he invented hydroxyzine and discovered the whole mast cell connection with IC. So he's, very, very credible doctor. So here he is doing a side project, as they are wont to do. So he's investigating supplements. And as he's looking at their mechanisms of action, he's going, I wonder if this would help IC. And he got more and more into it, more and more into it. And then he just got a hunch. He goes, you know what? Listen, we don't have new treatments for IC coming up. I'm going to try to make a supplement. And so he started a company called Algonaut. He's Greek. Algonaut means no pain in Greek. And his first big supplement was Cystoprotec. And then he also had Prostoprotec. And he just merged them into Cystoprotec because they're basically the same ingredients. And in this supplement are two bladder coatings, chondroitin and hyaluronate. And then he also threw in glucosamine and quercetin. Quercetin is known for an antihistaminic effect. And so when this came out, again, 15 plus years ago, it very quickly became, a showstopper in the IC world. And this is what Elmiron patients turned to immediately. And so that was brought up at the conference. And they asked Dr. Theo, well, what's the right way to transition from Elmiron to Cystoprotec? And he said a 1-to-1 swap. So kind of the same thing, So instead of, if you're taking 4 Elmiron a day, what they said is do 3 Elmiron and 1 Cystoprotec. Do that for a week. See how you do. If you do okay with that, then do the next week 2 Elmiron, 2 Cystoprotec. If you do okay with that, do 1 Elmiron, 3 Cystoprotec. If you do okay with that, then you can go to 4 Cystoprotec. And that's straight from the horse's mouth. I mean, I'm not making that up. That's straight from the horse's mouth. I worked with one lady who, I kid you not, spent her entire life savings on Elmiron because it wasn't covered by her insurance. All the money she'd saved was gone. And I asked her, she called me and she was in tears. She didn't know what to do next. And I said, well, did the Elmiron ever help you? And she went, no. And I said, why did you keep taking it? And she said, because there was nothing else. Okay, we can't use that excuse anymore. There's a lot you can try. And so Cystoprotec's been around for 15 years. Of course, it was off the market for 7 months. It's now back, reformulated. They removed one ingredient that had been linked to cancer, which is titanium dioxide. If you breathe it in, obviously this is a supplement, you swallow it, it's FDA approved. But anyway, there's a whole shebang from earlier this year. But Cystoprotec is now back in stock. But in the meantime, while we didn't have this, another company where, let's see, hold on. Here it is. Another company that I'm thrilled to be working with called Natural Approach Nutrition stepped up to the plate and gave us an alternative to Sister Protect that's called Bladder Rest. So Bladder Rest has all the key ingredients of Sister Protect, only more. The only one that they took out was glucosamine, but they're actually putting it back in. And so the nice thing about this, made in the United States, really good supplement, vetted by one of the top IC doctors in the United States. So many doctors are now starting to carry Bladder Rest because we didn't have Sister Protect. And the cool thing about this is it's $10 cheaper, which is great because we got rid of the middleman. There's no middleman. I can buy directly from the manufacturer. And then the best supplement on the market right now, in my opinion, is Bladder Builder. And the reason why is because it has more methods of action than any other supplement. So it's got the same ingredients as Sister Protect, only more of the same ingredients. It's got the same ingredients as Bladder Rest, but they also added collagen for the bladder wall. They added some beneficial probiotics, but most importantly, in my opinion, is that they added PEA, palmitoethanolamide, which in a new research study released last spring was remarkably successful at reducing neuropathic pain, nerve pain, and IC pain. It's been studied with many, many chronic pain conditions. The latest study was on IC. The results are staggeringly good. And so, in addition to Bladder Builder, if you like Sister Protect or Bladder Rest, or you just want to add a little pain component to it, you can buy Peora, which is just the PEA formula from the research study. And let me get that bottle. Hold on. Where is it? Hmm. I'm taking the one I'm taking. I'm taking Peora for because I have a lot of skin pain and neuropathic pain, and so I don't take it every day though. I come from a less is more perspective, really honestly, because I'm super sensitive to stuff. So when I took Sister Protect, I only took one a day. I couldn't go higher than that because it gave me loose bowel. So it's about finding what works for you. But anyway, Renee, here the point here is you say that your eyesight's very bad, and everybody says if your eyesight is bad, honey, you've got to stop the Elmiron. We got to try to save your eyesight. And so you've got other things that you can try. Be willing to experiment, be willing to try. Talk to your urologist. I'm so, so sorry you're going through this. And also, listen, Renee, attorneys are circling now. They're starting to collect clients, for possible class action lawsuits. And uh, if you, so there are two websites of interest. One is called pentosaneYedisease.org. That's a website I built that documents all the research. But the website you should go to is called elmironeyedisease.com. elmironeyedisease.com. That's run by attorney Michael Jansen, whose wife is an IC patient who took Elmiron, and they're doing a research study about this. And if you can, call them and do that research study. And come on over to our website and do our survey on this. Molly says, if I see a group pushing Elmiron, I push back. Good, you should be. I mean, it's really stunning what's happening. Absolutely stunning. All right. That was me. The lights were getting a little bright. Okay. Hello, Cheryl. Kathy says, Bladder Builder is what I changed to. Awesome. Molly's, does the book mention anything about flat feet? Yes, it does. Absolutely, it does. And it explains why that happens and how that influences your pelvic floor. Absolutely. You can get all the supplements right on our website. Just go to icnetwork.org. Don't go to icnetwork.com. It's ic-network.com. Or you can just go to icnetwork.org, click on our store, and you can get all the supplements in our store. We are the exclusive resellers for all of those right now. Bernadine says, what book are we talking about? The book that I'm talking about is this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. It is the best book ever written about IC, in my opinion. And it's also about muscles and nerves. Please, please get it and read it. It's amazing. Renee, I have an affirmation that I think would be very appropriate for you. My affirmation is, be bold and mighty forces shall come to thy aid. Be bold, hun. Be bold. It's okay to try things. It's okay to change things up. I mean, listen, hun. Listen. Dr. Parsons' transition plan for getting off of Elmiron solid, just reduce your dose, see how you do. It'll be an interesting experiment. Susanna said, I had no idea Elmiron could damage the eyes. You just found out watching this, hun. We have been talking about it, since Labor Day 2018. And that's one of the hardest part of my jobs, right? Because I consider myself the national IC support group leader. I'm the longest serving IC support group leader in the United States, and I'm the only one that streams live meetings. And frankly, I think that my history and experience as a support group leader qualifies me for that job. And part of that job is having to break bad news. And because I got the study, and like I'm like literally reading this right here at this desk, crying, and I'm not lying. I'm crying, going, "Oh my God, oh my God, oh my effing God! If this is true, this is devastating, devastating." And and so the question is do we hide it or do we share it? And I'm a patient just like you are. I believe in informed consent. I don't think anything should be hidden from us. I think you have the right to know the strengths and weaknesses, the benefits, the potential risks of anything that you're doing. And the hard reality here is that think about it, a letter to the editor in the Journal of Urology. That's how this was introduced to the urology community. I'm going to guarantee you 95% of the urologists in the United States did not read that letter to the editor, nor would they have been able to make any connection between eye disease and bladder disease in Elmiron. So you and I, we are the catalyst here. We become the educators here. And that's what I try to do in these meetings. I want to make you so strong, so knowledgeable, so informed that when you go and talk with your doctors, you can kick butt and defend yourself and advocate for yourself. And so you can find a fact sheet on this over on our website in our article on IC. It's a 2-page fact sheet. It has all the references. Bring it to every doctor you work with, your primary care, your urologist, your gynecologist, and educate them. Educate them about this. Because there are patients right now who could be going blind from Elmiron. And we've got to, now, and let me qualify that, Renee. We have patients, like I said, the first patient who called me back when we launched our first story, and you can watch my video on Facebook and on YouTube because I'm crying in the video explaining this to you guys because it's so devastating. We've got to do this. And the same is going to be true with the feet and this article. You're going to be the educator. If you can afford this, get a couple of these books and be willing to donate them to doctors because they're not going to have it and read it. And specific, but you got to read it first, and you got to point them to this chapter and say, look, unlikely suspects, the sacrum and the feet. Did you know that I have chronic pain in my left foot? Did you know that I pronate? Did you know that I have SI dysfunction? And did you know that that's been linked to IC and chronic pelvic pain? Maybe we need to treat that. Emily says, is there a way to contact me? Yes, absolutely. I do wellness coaching. You can sign up for wellness coaching on our website. And there's a charge for that. But honestly, for the last 25 years, people just call and I talk to them over the phone, absolutely no charge. However, and I do that all day. I'm usually on the phone every day for 4 to 6 to 8 hours with patients, and maybe 1 out of 20 actually pay anything. It's usually free. If you want to spend a lot of time, like an hour talking about your stuff, I'm going to ask you to pay for it. But if you want to spend 15, 20 minutes talking about it, it's usually not a problem. It's just first come, first serve. And right now, we have so many patients calling and asking for me that there can be a week before I can call you back. I mean, like literally on Friday, I finished up my entire waiting list, but it's just going to start again on Monday. So go to our website. We have an 800 phone number, 1-800-928-7496. You're absolutely welcome to call. Extension 1 is for sales and any orders. Extension 2 is for the corporate office. So if you're a vendor, but a lot of patients call that, but try not to. Extension 3 is our support line. And I answer that phone line every day. And if I'm not working with a patient and you got me, hit me up with your questions. I won't charge you a thing for it. We're a support group. Oh, look. Oh my God. I just tried to do it again. I just tried to sit on my foot again. Oh my God. Which of course triggers pelvic floor dysfunction and SI dysfunction. Oh my God. See? Leanne says, ureter reimplantation was from reflex as a child. Oh, I've been suffering since the age of 3. I get it. Do I have a specialist in Canada I recommend? I don't. We have a new Canadian IC support group that might be able to help you, though. And they have a group on Facebook. So just Google Canadian IC or search for Canada IC on Facebook, and you can get in their group. And I do have their information on our website under our international IC support group listings. So go to icnetwork.org and you can see that. Leanne says, 35 years of battling, and I appreciate how focused everyone has been on my bladder and pelvic floor, plus a lot of gynecological problems, but my kidney is what paralyzes me, and I can't get anyone who gives it weight or relevance. So, girl, you got to go to a kidney specialist. If you're on the West Coast, Marshall Stoller at UC San Francisco is a renowned kidney expert. I know him because I was one of his patients because he used to do IC before he just went to kidneys full time. So again, Leanne, in your case, I think you need to be at the national level. And if there's any chance you can get yourself to Ken Peters at Beaumont or Robert Evans at Wake Forest, I think you deserve that. You deserve to work with somebody of national, of a national repute. Got to remember the difference between local, regional, national doctors. Local doctors simply, they're the they're the workhorse. They're the ones that handle the simple things. And when they get a complex, and their depth of experience working with complex cases is pretty limited, because local doctors send their complex cases to regional doctors, and regional doctors are usually local universities. So here, I'm in Northern California. I live in Santa Rosa, California. My local urologist here sent me to UC San Francisco to my regional doctor, who happened to be Marshall Stoller. And he was good. He was pretty good for what we knew back then. But the challenge is that 25 years later, I still have chronic pelvic pain. And the question is why? Now we're figuring it out. We're figuring that really it's musculoskeletal, as exemplified by SI joint dysfunction, chronic pelvic tension, and other physical signs like abnormalities in my feet and other things like that, which this book beautifully describes. And so more complex cases, like, let's see if I can give an example. Yeah, well, if Sue's still here, I mean, if Sue's here, so Sue's case is very, very interesting, and she's talked about this publicly, so we can talk about it. Sue had, she was a horseback rider, a very, very accomplished horseback rider, and eventually had bladder symptoms for 30 years. None of the bladder treatments worked for her at all. She attended one of our meetings. One of the things I say at my meetings is, you are an anatomical mystery to be solved. We can no longer make broad statements about anything related to IC. Anything. You are an anatomical mystery to be solved. They've got to look at your entire pelvis to try to understand why you're struggling with the symptoms that you're struggling with. Even if they appear to be bladder symptoms, muscles can trigger bladder symptoms. And so she went back to the doctor and she said, okay, I want to try to figure out what's going on with my anatomy. And they did a MRI. They either did an MRI or a CAT scan. And you know what they found was a knob of scar tissue in her piriformis muscle right next to her pudendal nerve. And in fact, that urologist had never, it's a very, very odd location, which clearly is why, number one, bladder therapies didn't work for her. And number two, whenever they tried to do pelvic floor physical therapy and touched it, it hurt like hell. Now they know why. They found a structure. And now the question is what to do about that structure. And there's a lot of sober reflection about what to do. It's in a very unusual place. And she remembers falling off a horse right on that spot. So clearly, it's probably scar tissue related to a trauma, or it could be a very, 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 very tight pelvic floor trigger point that it's completely dysfunctional and frozen. And so there you go. Somebody 30 years of bladder therapies never worked. Now we know why. And guys, you also got to remember, listen, God didn't give you the skills to deal with this when you were born. This is scary shit. It's scary to have pain. It's scary to not be able to sleep at night. I spent a couple of years sleeping. I was afraid to go to sleep because it hurt so bad at night. And so, and I know some of you know what this is all about because it's like you go to bed later and later because you just don't want to lie down and try because it's going to hurt, right? And so I got stuck in this pattern of going to bed at 2 in the morning and then 3 in the morning and then 4 in the morning. And which just and I finally broke out of it like 5 years ago, 6 years ago. I was actually going to bed at 10, 20 years of going back at 1 or 2 or 3, all from that residual anxiety about being so uncomfortable at night. And then I had the freaking hysterectomy, and guess what happened? It started again. And because I had pain, and it brought me right back to being kind of afraid to go to sleep again. And so I don't go to sleep until 2 in the morning, sometimes 3 in the morning. It's crazy, so if you're dealing, God didn't give you the skills to deal with this. And you don't have to do this alone. There are people out there who have been there, who have got lessons they've learned that they can share with you. And that's why support groups can be good. But ultimately, in the end, you got to build some anxiety management skills. And you're not going to learn that on Facebook. This is about skill building here. You're not going to a therapist to try to figure out why you have anxiety. It's not necessarily about going back to your childhood and figuring out what the hell happened to you back then that gave you anxiety. I've had anxiety my whole life. It runs in my family. And when I was growing up, I had a rapist murderer in my neighborhood who murdered a neighbor and who went after me a couple of times. You can damn well bet I grew up with anxiety. I still have some anxiety from that. It's never far away. It's a profound and important part of my life. That's why I don't trust men very well. It's very hard for me. When you've been abused, you get it. You know what I'm talking about. But I got to the point where I just kind of like shut down if I had to go to the doctor. I wasn't just shutting down sleeping. I got to the point where I was afraid to go to the doctor because it was like every time I went to the doctor, I felt like they were hurting me. And so something would happen, I'd get a cold or whatever, and I'd call to make an appointment with the doctor, and then I'd have a total panic attack. And I remember that the one that threw me over the edge is I was out pacing in my backyard crying. And of course, when you're when you're anxious, here's like the funny thing, right? The thing that's so weird. And a lot of this goes back to the prehistoric parts of our brain and the fact that anxiety is about how we defend ourselves. There's really good reasons for anxiety. Um, um, I had before this one appointment, I just had this massive panic attack and I knew I needed to go to the appointment. And in your brain, you catastrophize. It's like, what if, what if, what if this is cancer? What if this is this? What if this is that? And you know how weird it is. You made an appointment with your doctor, right? It's like you feel bad, but after you've made that appointment, you feel so much worse. It's like, oh my God, this is going to be really bad, right? And your anxiety goes up and up and up. And then you're in the car driving there and you're doing your deep breathing. And it's like, oh my God, this is so bad. You get to the doctor and you're in the waiting room and you're like freaking. And then you see the doctor, he goes, "Oh, Jill, this is fine. I know exactly what this is no problem." And all of a sudden the anxiety's gone. And you walk out with a giant smile and you don't feel bad anymore. Like I felt great. How could I 15 minutes early feel like I was dying? 15 minutes later, it's like, "You're great. I'm fine." That is the effect of anxiety on your brain. That is the effect of anxiety on your brain. We call it the runaway train of emotion. And number one, when you have a flare, it's very normal to get emotional about it. But you kind of have to ask yourself, okay, it's a flare. Do I need to get upset every single time? No, you don't need to. It's like a flare. The flare that you have when you ovulate, is it worth getting upset about a 1 day flare? No. Is it worth having a panic attack for a 1 day flare every single one? No, it's your hormone flare. You know exactly what it is. Nothing to get sweat about. And so, what they teach you in mindfulness and what they teach you in anxiety classes is learning how to step off the runaway train of that anxiety and that emotion. That's like, it's a flare. It's okay. I know what to do. I don't need to get upset about this. I get it. I get it. And that's the thing is pain doesn't scare me. It doesn't, I'm going to say it this way. Bladder pain doesn't scare me at all anymore. It doesn't. I know what to do, man. I got my toolkit. I'm an experienced veteran when it comes to managing bladder symptoms. I know what to do. And so I don't look at it as I don't need to get scared. I don't need to get frightened about it anymore. I've got my skills. But all you got to do is say the word cancer, and I get terrified. And so when I had that early uterine cancer 2 years ago and had the successive bad tests and then procedures and then a DNC and then, bad news, bam, it was pretty stressed, but I had my anxiety management skills. And I had taken a great anxiety management class called Phobies, and it taught me how to get through it. And I did not have a single panic attack facing uterine cancer. And then right before Thanksgiving of last year, they thought I had breast cancer. They thought I was one of the rare cases. I got uterine and breast cancer, and they scared the living daylights out of me 3 days before Thanksgiving. And that turned out to be nothing. So let me give you this great anxiety management tip. Okay. So when you are in that anxiety chain, there's a lot of negative thinking going on. It's like, what about this? What about that? It could be this. It could be that. Oh my God. Oh my God. It's never going to get better. It's going to get terrible. I'm going to have this my whole life, which is that normal cascade, right? Every time you have a negative thought, you give yourself a burst of adrenaline. Adrenaline stimulates fight or flight response. When you've got adrenaline, what do? You're tightening your pelvic floor muscles. You're getting ready to run. But you've just had negative thought after negative thought after negative thought after negative thought. You have massive adrenaline going through your bloodstream. When you have massive adrenaline going through your bloodstream, holy hell, it's chaos. It is emotional chaos. So, what this class taught us is how to control adrenaline. And it's really, really easy and it works. So, whenever you have a negative thought, you visualize a stop sign. Just close your eyes for a moment. Okay, so here's my negative thought is it could be cancer. Okay, stop what I'm doing. I'm going to visualize a stop sign. Nice, okay, big red stop sign for a couple seconds. Then I'm going to take a nice, slow, deep breath in for 3 and out for 3. Do it with me right now. Come on, let's do it. In for 3 and out for 3. That oxygen that we just put through our body turns off adrenaline. So I had the negative thought that gave me the burst of adrenaline. Then I had the deep breath, which turned it off. Okay. Stop sign, deep breath. Now you have to minimize the thought. You got to remind yourself it's a thought. It has no power. So what I say to myself is, oh my God, Jill, it's a flare. You're ovulating. It's nothing to get worried about. Or what I say is, oh my God, Jill, you're not God. You can't predict the future. For all you know, it's going to be a great doctor appointment tomorrow and you're going to meet some hot guy and you're going to fall in love with him. You know what I mean? You know what I mean? Right? Okay, so stop sign, deep breath, minimize the thought. 3 steps. So in the class, when they taught us a step, and this was created by a surgeon who had anxiety disorder in the OR. Okay, you can think you want a surgeon with anxiety disorder operating on you? He was brilliant. He was brilliant. He helped so many people. It's absolutely amazing. So that we walk out of the classroom, and this is at my local hospital where I took the class, and they go, now we're warning you, you have no clue that virtually every thought going through your brain is negative and scary because you are so on adrenaline right now. That's fight or flight. That's everything that's happening. So we need you to be really, really attentive here. Every time you have a negative thought, you need to do it. Stop sign, deep breath, minimize the thought. And you're going to do it hundreds of times. You know, we're all like going, yeah, right. Okay. So we leave the classroom and realize it was hard for me to even go to the class because I was kind of afraid of going to the doctor, going to the hospital, right? But I got there. And I was doing it in the car. That first 24 hours, I did it hundreds of times, but let's just say 100. I had no, I really did not understand how my thinking had become so destructive. It was just scary thought after scary thought after scary thought after scary, and I couldn't control it until they gave me this. And so the first day I did it like 100 times. The second day I did it like 50 times. The third day I did it like 25 times. By 5 days later I was doing it once or twice a day, and I was so much more calm. It was amazing. I felt so much better. And that is now the technique that I use. And I was doing that on the way to the hospital, waiting for a hysterectomy and waiting to see if I had uterine cancer. And I didn't have a panic attack. And I didn't have panic attacks last Thanksgiving, waiting for my test results and at Thanksgiving, thanks to learning how to control the chemicals. And I guess I just thought that, like, I always knew it was a problem because I knew that I had an extraordinary childhood because we were dealing with this very violent person who was hurting a lot of people and had hurt me pretty badly and then murdered my neighbor. Another girl raped and murdered her and then tried to kill her fiance. He survived, but she did not survive. And so I had a good reason for being anxious. I had a good reason for being anxious leaving the house. And you know, uh, it is what it is. It is what it happened. It is what it is. I can't change it. The past is over. It's done. But I completely understand now that I don't have to live in the past anymore. I have control over today and my ability to learn new skills, get me through the hard moments, and to be humble about it and just say, you know what, I don't know how to deal with this. Can somebody help me? I don't know how to deal with, oh God, you want to be real personal here, is I'm caring for a 97-year-old and a 90-year-old. And I'm now dealing with the inevitability of what's going to happen. And I'm getting to that point where I'm going to need to talk to somebody about that. And that's okay. I mean, I've already talked to a lot of people about it, and I can be academic about it, and I can do this and I can do that, but it's a very, you know, we can't linger in the past. Today is the day we have to live and to use. And I'm going to choose to try to live it and use it as constructively as I can. And I'm always trying to build my knowledge level, and I'm always trying to improve my skills, not only for me to get through my crazy life, but to try to help you. And I want you to do the same thing, because you're going to be able to help other people. The ultimate gift of living with IC and having IC, you know what the best gift of it is? Is that you will never, ever, 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 ever walk away from somebody in pain anymore. Because you know what it's like to be alone in pain. You know what that means? That makes you a better friend. That makes you a better mother. That makes you a better sister. That makes you a better father. You have learned compassion like you've never had before. If this hadn't happened and you were living your happy, lucky life, you would never have known the dark side of what it is like to live with injury. Now that you know what it's like to live with injury, your compassion level is off the charts. At least I hope it is. Because we are in this together, my friends. We have got to work together on this, right? Christine says, I took a probiotic one day last week. It put me in a flare. There's certain thing. Yeah, Christine, girl, I don't know. This is one of the odd mysteries to me, is that there are many patients who take probiotics and they're absolutely fine. I can take a probiotics, never bothered me. But there's definitely a small subset of patients who take a probiotic and it flares them. And I do not understand why. It's either something in the capsule that's irritating you, or I think it represents a biome. I think that there's something going on with your biome, but we just don't understand why. Wendy, I just quit Elmiron on my own. My doc said we would do it maybe 5 to 6 months. That turned into 3 or more months. I quit it. And the 2400 gabapentin I was on, I take Urabel and water. Okay. Yeah, I mean, we've got some probiotic studies from the MAP Research Network. We know that we're deficient in some important bacteria and we have an overabundance of others. Hopefully, somebody's diving into that a little bit more. I'm pretty sure I saw some either clinical trials or research studies that are trying to focus a little bit more on the biome and how that changes, because that undoubtedly plays a role too. Question is does the biome change in response to chronic pain? So if chronic pain is stimulating the nerves and the nerves get overloaded and the nerves then stimulate the bladder and the bowel, if when you overstimulate the bowel, does that somehow change the microbiota and the bacteria in there? I don't know. I mean, it's fascinating. Susanna, the Elmiron fact sheet is over on the IC Network website. If you go to the front page of the IC Network, let me just come on. I added a bunch of stuff, so things might have moved around now that I'm kind of like functioning again after the craziness of last year. So if you go to the IC Network website, just go to the front page, icnetwork.org, under research and clinical trials. is a picture of a woman holding her eyes like this. Click on that. And right underneath the first paragraph, it says download our easy printable fact sheet to share with your physician. And that's what you can print out. And I don't remember, did I? Yeah, it's 3 pages now because I added the progression study. Okay. Laura says, I was on Elmiron for 23 years, recently stopped taking it because of the eye issues. I did not notice any difference after going off of it. Now it makes me mad that I was so obviously taking it for no reason. Laura, thank you for sharing your story. See? 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 Renee, that should give you hope. Laura, right there. Joan says, I've had both feet and arches rebuilt in the last 5 years. Interesting. Sue says, I would love to hear what your podiatrist says about the Morton's toe when you go back to him. Yeah, I'm going to try this spring to get back in. Terry is linked to a book called Treating Chronic Pain, Pill-Free Approaches to Move People from Hurt to Hope. I don't know about that book. Usually I don't like it when you guys refer something that I haven't had a chance to read first. But it is what it is, and I know it was done with the best of intentions. Oh, there you go. Cool. It's talking about mindfulness. Okay. Thank you. Thank you for sharing that. Talks about how opiates used and all that sort of stuff. Awesome. Thank you, Terry. Thank you for sharing that. It's not relating to the pelvis, so to the degree that this book is. So really, the point is, please go over to Amazon right now and buy this book. $9 Kindle. Come on. I think it's going to knock your socks off. And I'm telling you, for once in your life, study it. You know how when we get older, we skim stuff, and God forbid, right now, everybody wants things fast and easy. You cannot do this book fast and easy. It starts with an anatomy lesson. You got to learn the anatomy. You got to learn the muscles. You got to learn the nerves. You got to learn the interrelationships so that you really understand why a foot problem can trigger IC symptoms. It is excellent. Excellent. But you're going back to school. I've gone back to school with this book. And I'm actually loving the quiet time. I get to sit at my kitchen table, and my dad has to turn the sound off on his laptop because he's usually watching videos, and to just sit there and just learn. Oh my God. Yeah, Susanna, Amazon is the only place to get this book. That's the funny thing about this book, Breaking Through Chronic Pelvic Pain, A Holistic Approach for Relief by Dr. Jerome Weiss, is it's self-published. It's a huge book. I mean, it's 400, how many pages is it? 420 pages. And I immediately wanted to contact the publisher to so that I could buy it and sell it to the IC network and sell it through the IC network. And it's actually published by the doctor, but it does not give contact information. When he retired, he's trying to do it gracefully. And this is his picture, by the way. This is him right here, Dr. Jerome Weiss. And honestly, you'll learn more reading the 2-page preface or the foreword. Look at the foreword. I've got the foreword highlighted. I mean, every page, and then the preface highlighted. Look at this. I never do this with books. It is just, how can treating one structure that hurts while ignoring other structures that are contributing to the problem with the latest miracle drug, high-tech equipment, or surgery stop the painful bombardments caused by neurological changes that were ultimately created throughout the body? Even when surgery is performed, I found that unless the root cause of the problem and all the contributing factors are addressed concurrently, the patient's symptoms will either continue or eventually return to plague them to one degree or another. Chapter 1, the problems nobody talks about. I mean, honestly, the best book ever written. Like I said, we're getting ready to bring another book written that the IC Network is publishing. We're probably still going to do it, but now that I've got this, I've got to talk with them and maybe rewrite portions of that book to include this knowledge. I don't know. Ugh. Joan says, oh my God, there it is. I hit a tree, prepubescent, age 8 or 9. Blood in my underwear when I got home from sledding, hitting a tree. This could definitely have been the precursor. Yeah, absolutely. I mean, it's funny when I talk with patients, so when patients call, hi, Robaline, nice to meet you. When patients call and, we're talking about their symptoms, I always say, listen, we can't talk about therapies until we talk about your anatomy. So don't talk to me what you've taken. I don't want to hear about what you've taken yet. I want to hear about when your symptoms began. And it's like, it's like finding a needle in a haystack in a way, but a lot of times patients don't share things. And so, I tend to go through the subtypes, and then based upon what they're saying, we try to go back in history. So for the pelvic floor patient, it's like, okay, take me back 20 years. What was happening 20 years ago? And they go, well, nothing. I go, did you have any babies? Like, yeah, okay. How was labor? How was delivery? Was it okay, or was there any problems? And they go, oh yeah, I got torn. It's like, okay, that's important. Now let's go back to when you first felt your symptoms. Do you remember having any symptoms as a child? And some of you do, and some of you don't. It's like, okay, so explain to me what was happening, when that was going on. And it's so interesting. Like 24-year-old guy, severe pelvic pain, severe frequency urgency. He dropped out of college. He's basically very similar to the patient that was described in this book, where he basically stayed in his bedroom, got very, very profoundly depressed. And he was diagnosed with IC, taken a lot of medications, stuff like that. And so his mom is desperate to help him. She's desperately worried for her child. And so she calls me, and even though he's older, he's like 24, it's like, hon, you can't really speak for him. He can speak for himself. She's like, yeah, but he won't talk to you. So I'd like to talk to you first about it. It's like, okay, so run it through for me. Let's hear. And he's like, well, it started when he was in high school. He was a football player. And it's like, okay. So we know, and then we looked at his symptoms. His symptoms were clearly pelvic floor symptoms. We could definitely tell, especially based upon the fact that he was a football player and he took a lot of pelvic injuries. It's like, okay, so that kind of helps us narrow this down. He was playing football in high school. So eventually, I think I got to talk to him the next day. He called me the next day. And it's like, okay, so walk me back to when this began for you. And he goes, I can tell you exactly when it began. I was like, okay, when? He goes, our football team went on a ski trip. And I went, okay. He goes, I fell off the ski lift on my tailbone. And that night I had these symptoms. And I went, okay, did you ever tell your doctors that? And he goes, no, I didn't think it was relevant. It's my bladder, right? It's like, no. And so he knew exactly what triggered his symptoms. Or the gentleman who was sliding on his wooden floor in his socks and fell on his tailbone and then fell down the stairs on his tailbone butt first. And he too, extreme bladder symptoms, frequency, urgency, pressure, pain. So he talks to me and he talks to somebody else I know. It's like, dude, this began after a month. If you fell on your tailbone, right? It's like, yeah. He goes, and I went, have you had this assessed? He goes, nope. Oh, what are you doing? Taking antibiotics? Wait. Why? He goes, because they said it's prostatitis. I was like, but did your urine culture test positive for bacteria? No. Why are you taking antibiotics then? He goes, well, okay, they put me on Flomax, prostate meds. Like, wait a second. Wait a second. Have you had a pelvic floor assessment? No, what's that? He goes and has a pelvic floor assessment. He's got a injury perfectly described in this book. Perfectly described in his book. What's the treatment? Find the injury, find the trigger points, and resolve the trigger points with manual myofascial massage. And if there's any nerve issues correlating with that injury, then we're going to work on the nerve too, right? Up, there's my dad. Hey, we're still going. Ooh, I got boxes. You want to say hi, Dad?
Hello.
Well, come over here so people can see you.
Hello there, young bull. This old man says hello.
Hey, man. It's pretty good for 97 years old, right? Okay. Amazon fulfillment. Oh, it's heavy. What the heck is that? I have no idea. It might be for the IC network. Let's at least open it. We'll do a little reveal real quick. Let's just see. Oh, yeah, baby. You know what this is? You know what this is? More books. I think I got 8. Oh, I'm so excited. All right. You know what that means? You know what that means? Oh, whoops. Hold on. It's time for the giveaways. It's time for the giveaway. This is going to cost me a lot of money to mail to you guys. This is my gift to you. This is my gift to you. Here is our giveaway for this meeting for those of you who have been sticking around for almost 5 hours. I'm going to give one to Facebook and one to YouTube. All right? It's not going to be easy. Okay, I got to come up with a question. Ooh, 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 ooh. Okay. Hey, man, you're going to have to work for this one. You're going to have to work for this one because this is out of my own pocket. This cost me $50 to send these to you guys total between the book and the shipping. So it's not going to be easy. It's going to be hard. Hold on. Let me look at my notes. And let me see if I can find a good question. To see if you've been paying attention. Oh, you know what? Okay. This is, I mean, it's kind of easy. It's kind of easy. And I've got my, thank you, Donna. I got my Post-its here. I got my books here. So I want you to name one let's see. I want okay. Hold on. I gotta scroll down. Okay, so hold on. I gotta cue it. I gotta move my YouTube window so I can see both at the same time. Ooh, the lights are changing. My makeup's falling off. You're seeing the real me. Oh, that's not good. Vicky says, what's Peora? Peora is palmitoethanolamide plus resveratrol. It is a over-the-counter supplement that has been tested specifically with IC and was found remarkably helpful at reducing the pain and discomfort of IC. At 3 months, 87% of patients using it had a significant reduction in their pain. At 6 months, every single patient using it had a significant reduction in their pain, and 25% were pain-free. These are patients who primarily had nerve pain. It's been studied with many different pain conditions in Europe quite successfully. Pura is available on the IC network, and it is only $29, which is very cool because it's very affordable. Okay. All right. So here's your question. What is a oh man, oh, might be too easy. Crap, 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 crap. Okay, it's not going to be Morton's toe. I'm not going to say, what do you call the condition where you toe? No, it's not going to be Morton's toe. Okay. Oh God. Name the first person on YouTube and on Facebook. Name one of the red flags that you look at your foot at to see if you could have Morton's toe. That's your question. Name one of the things that we look for to determine if you might have Morton's toe. So when you look at a foot, what are we looking for? What are we looking for? That's your clue. All right. All right, Vicky Hooley on Facebook is the winner. And oh, Vicky, you're also on YouTube too. Okay. All right, YouTube. I don't have anybody on YouTube who has answered the question yet, but there's only, there's not a lot of people in there. Okay, so YouTube, if anybody wants the book, give me one sign of Morton's toe. One sign. Can you give me one sign of Morton's toe? Vicki, if you can email me icnetwork@mac.com, icnetwork@mac.com, your mailing information. I need your mailing address and I will mail it to you tomorrow. Okay. Oh, Rebecca, you were so close. Dawn, you were so close. Vicki was just type faster than you did. Okay, for those of you on Facebook, nobody on YouTube's answered the question. You already see the answers there. Feel free. Unless I'm not seeing YouTube scroll down. I don't know. Is there a problem with YouTube? I'm not seeing anybody on. Testing YouTube 1, 2, 3. All right, Sherry Diggs. You won on so. The answer was a hammer toe, or the second toe longer than the first toe. All right, so Vicky Hooley, you're getting one. Here is your book. And Sherry Diggs, and Sherry, I think I already have your address. Pretty sure, don't I? All right, Sherry Diggs, there's yours. I will take care of that tomorrow. Today was one of my friend's 60th birthday parties, but I absolutely could not do this meeting. I'm so excited by this. So I've missed a birthday party, but that is okay. Barbara, if you're watching, you know I love you. Of course, she's not. She's at her birthday party. Joan says, I knew it. Books. Artie says, amazing at 97. Yeah, he's pretty perky. Anna says, you need another girl. I'm going to be doing sessions on this book all year. And I'm really going to try to find Dr. Weiss and see if I can get him to come do an interview with us. And if not that, a Q&A. He's absolutely fantastic. My dad is he's a handful. Let me tell you, when the power is out, he paces. He's like, because he's a ham radio operator, electrician, so he's always thinking about how to wire the house. So like wants to connect the generator to the house. It's like, Dad, you're 97. We're not going to do stuff like that right now. We have a generator. We're fine. Thank you, you guys. If you and listen, if you found this helpful, please support our work. Please support my work by coming over to the IC network. And hey, you know what you can do? As you can get our magazine, the IC Optimist, and I'm telling you, our winter magazine is going to be dedicated to this book, and I will be writing most of it about this book. And so you can become a member of the IC Network and get our magazine, the IC Optimist, for um, just $25 a year, 4 magazines a year. Pretty good. And depending upon the membership you get, there's more things you get. You know, if you do the $50 membership, you get more stuff. You do the $100 membership, you get a cookbook and other stuff too. So anyway, what I should do is I should think about that. All right. And Lucinda said tingling toes. No, tingling toes, I do not believe is a sign of Morton's toe. I don't think so. Look at all you guys. You paid attention. Yay. Go 49ers. What's the score? Vicki, send your information to, I just go over to our website and you can go to the contact page and send us email, or icnetwork@mac.com. icnetwork@mac.com. All right, guys. Well, listen, it's 5:30 here. We've been going for 5 hours, and I loved every minute of it. I loved every minute of it. Lucinda says, "Can you give me advice on living with endo?" You know what, Lucinda? There's a fabulous nonprofit here in the United States called the Endometriosis Association. If you can, go on over to their website. I think it's endoassociation.org or endometriosis.org. They've got really, 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 really good resources there. One of the things that they taught me about endometriosis that I really resonate with is we now know that the abnormal growth of uterine tissue is often stimulated by various chemicals. And one of the things, I mean, it's a very interesting progression because the IC movement and the endometriosis movement basically got started around the same time. And uh, they were very, very focused on research, whereas the IC Association had a bit of a different focus at the time. So, as they were scanning medical journals, they found this little obscure little research study that was published by a chemical safety group on dioxin. Dioxin is considered the most toxic chemical ever made by man, and it's created by burning plastic. And the chemical industry was trying to prove that dioxin was not harmful. And so they were giving a group of monkeys ever higher doses of dioxin. This was back in the 90s, early 90s, or even in the 80s. And a monkey died. And they did a autopsy of that monkey, and it was filled with endometriosis. And then another monkey died, and it too was filled with endometriosis. And they, based upon this data, these researchers concluded that dioxin as a estrogen mimicker triggered the growth of endometriosis. And they published their findings in this obscure little chemical safety journal. Well, somehow the volunteers at the Endometriosis Association found it, and they petitioned the it was a National Institutes of Health study, apparently, something like that. So they petitioned the NIH to the researchers were going to abandon the project, and they were going to sell off the monkeys or euthanize the monkeys, either which is disgraceful, right? Do not even talk to me about animal research. I gave up my entire career in pharmacology because of stuff like that. It's just shit. All right. So they petitioned the National Institutes of Health and asked if before they sold the monkeys off, if they could do laparotomies, keep the animals alive, obviously, just do a laparoscopy and look and see if they had endometriosis. And that happened. And they found that every monkey exposed to dioxin had endometriosis and that it was a dose response curve. The lower doses of endometriosis meant lower endometriosis. I mean, the lower doses of dioxin contributed to low doses of endo. The higher it got, the worse the endo. And that was a very powerful moment for the endometriosis community because that was when they learned that endometriosis is, in fact, for many patients, apparently a man made toxic exposure. And so I did an interview. I did a big piece on endometriosis in our magazine like 5 or 6 years ago. And I interviewed the executive director of the Endometriosis Association. She impressed the hell out of me. Oh my God. I wish we could have had somebody like her in the IC world back then. We didn't. Um, and she taught me a lot about that. And then she also, you see this about once a year now, you see new chemicals that have been linked to endometriosis. And it helps us understand why back in the 50s, there were just a couple thousand, maybe 10,000 cases of endometriosis, whereas now there are millions. And they believe that's really due to wide scale chemical exposure. So, one of the points that the Endometriosis Association makes, that I make on our website also, is that it is very, very important that you remove chemicals out of your daily life. Critically important. Like, you should not be using any extraneous chemicals in your home. You've got to go natural, plant based stuff. No Febreze, no, you know, scented candles from China, oven cleaner, anything at all like that, that you know you and I breathed in over in our lifetimes. Those chemicals can have a consequence if they are estrogen mimickers. And when you think about dioxin, the problem with dioxin is when you burn plastic, it goes throughout the environment and it accumulates in the environment. And so then it accumulates in the grass, and then it accumulates in the animals that eat the grass, which then accumulates in the milk that it's harvested from the animals, which then accumulates in our body, right? And even though they haven't allowed plastic to be burned in, I think, a couple of decades, it's out there. So cleaning everything out is critically important here. Like, you got to be really careful buying new furniture. Make sure there's no fire retardants in it. I mean, it's just the chemical industry, they know that they're producing chemicals that are toxic to people. I mean, all you have to do is look at glyphosate. Glyphosate, also known as Roundup, right? Which is responsible for, the destruction of ecosystems everywhere. You want to know why the monarch butterfly population is almost gone? It's because they spray all the roads around the farms with Roundup and kill the milkweed. They've got nothing to eat. That's why monarch butterflies are almost gone here in California. Like 90% are gone in the last 5 years. So the thing about that is the growers learned that if they sprayed Roundup on wheat a couple of days before they harvested, I think it enhanced protein content or something like that, and they got more money for their wheat crops. Of course, the ripple effect is devastating because now if you go to websites like the Environmental Working Group, you can look at your Oreos and see that your favorite cookies are filled with Roundup. That's banned in Europe because it causes cancer, but the chemical industry has such influence in the United States, it's still here too. So I'm sorry, I'm a trained chemist, and as a chemist, chemicals scare me. And I've been there. I've had them all over my hands. I've breathed them in, and I think it's very, very important we clean up chemicals out of our home. I'll get off my soapbox here. Sorry. ICNetwork at mac.com. Oh my God, 27 to 749ers. Are they in the third quarter? Vicky, I will, just go to our website and you go to the contact us page and you can just send me your email that way, or it's just icnetwork at mac. That's M as in Mary, A as in Apple, C as in Charlie.com. icnetwork at mac.com. Thank you, Sherry. Got it. Lucinda says, I'm on lamotrigine for epilepsy. I take a large dose because I don't know, hon. I've never heard of that med. Let's Google it and let's see. Let me go to one of my trusted drug websites. It's an anticonvulsant. Common side effects: headache, dizziness, blurred vision, double vision, tremor, loss of coordination, dry mouth, nausea, vomiting, stomach pain, diarrhea, fever, sore throat, runny nose, drowsiness, tired, back pain, sleep problems. Those are the common side effects. Serious side effects: skin rashes, Stevens-Johnson syndrome, multi-organ hypersensitivity, which is due to a drug reaction with eosinophilia, low blood counts, changes in mood or behavior. Okay, so Lucinda, there is a condition called eosinophilic cystitis. Eosinophils are white blood cells. And generally, when there is a problem in a specific area, uh, I've worked with several patients who have eosinophilic cystitis, and when they do a biopsy of the bladder wall, it's filled with white blood cells. One of the patients was a young girl who they later discovered that her well water was contaminated with pesticides. So if you have noticed an increase in frequency, urgency after taking this medication, it's right here, multi-organ hypersensitivity, which is also called a drug reaction with eosinophilia and systemic symptoms. Definitely want to tell your doctor about that. That's a challenging med, my dear. It can also interact with other meds. Yeah, I mean, if you notice any changes in your bladder, you definitely want to talk to your doctor about, because eosinophilic cystitis, happens. Thank you, Sherry. I see your email just came through. Morton's toe is bad enough. Can it make the third toe longer? Well, one of the things that happens is that your foot can actually flatten out. It can get wider and flatter, which would completely distort the way the other toes are presenting. Molly Nelson goes, oh, wow, that's crazy. I have endometriosis as well as IC, PCOS, and Hashimoto's, and I'm actually getting a laparoscopy next week. I'll have to remember that dioxin. Yeah, guys, remember years ago when we used to burn Christmas paper and, Christmas morning, the metal Christmas paper, the plastic ribbons. Imagine what we were doing to our environment. That's why we don't burn Christmas paper. And I just think we need to get rid of all plastic as much as we can. That's what I'm trying to do. Can we watch this full video later? Absolutely. It will be on YouTube and Facebook. Holy crap, the Niners are doing great. Awesome. Joan says some people with eosinophils have asthma. Yes, that's true. Vicky, I will check my email right now. Vicky, I have your email. Awesome. You know what, you guys? Listen, I have had a great time. I am, given all the crappy bad news we've had with the Elmiron, to be able to come on and talk about something that's encouraging and promising and might give you a clue and an answer to why you have pelvic pain is just so exciting to me. It's so freaking exciting. I'm so happy to share it. I want you to get better. I really want you to get better. And, as you're trying to solve your mystery, I'm trying to solve my mystery, and I am much closer to solving it now. So, listen, so it's time for your homework. I'm going to give you homework. You always get homework from me, and I need you to do it. Homework number one, seriously, honestly, I want you to order the book or save your money so you can order the book. $9 on Kindle, $35 in print. Remember, nobody's paying me for this. I don't get a kick out of anything. I'm just telling you, as your support group leader, this book has the potential of changing your life. Please do it. Please do it. You will learn so much from this book, just like I'm learning from this book. 15 minutes a day, I need you to do something for your spirit. This is something I've really struggled with, by the way. Can you just find your quiet time and do something nourishing for you? This is hard work. You are working your tush off right now, dealing with pain, dealing with IC, all these doctor's appointments, all trying to figure this out. And it's exhausting and it's hard. And you've got to respect the fact and be gentle and kind to yourself. So for 15 minutes a day, I need you to do something that will give you some nourishment, whether it is taking a walk, although granted, if you're in Newfoundland, you have 13 feet of snow right now and your cars are covered, but you know what I mean. Go to church, watch something encouraging, read poetry, get off of the internet, do something for you. Okay? For 15 minutes a day, I need you to do something for your body, for your bladder or your pelvic floor. Or, come on, for 15 minutes a day, you can figure out how to make a toe pad if you have Morton toe. Okay? Super easy. For 15 minutes a day, I need you to improve your knowledge level. And this book is going to do it. Just don't even look at any websites right now. Read the book. Read the book. It's going to knock your socks off. And then, most importantly, and this is what I do every day for about a half an hour to 45 minutes before I go to bed, is do something funny. Laughter modulates pain downward. When pain is accompanied by anxiety and fear, it triggers a fight or flight response. It triggers a very visceral reaction. Your brain is going, uh-oh, something's big is happening, and it intensifies the pain to get your attention. If pain is accompanied by laughter, your brain goes, maybe this isn't so bad, and your brain will minimize the pain. And so for 15 minutes a day, would you please, 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 or 30 minutes a day, 45 minutes a day, at the end of the day, I need you to laugh. Watch something funny. When was the last time you really laughed? Whether it's watching animal videos on YouTube or watching an old episode of I Love Lucy or whatever. I'm dating myself there. Whether you know what I mean. Watch a comic. Watch something funny. I was very serious when I was in college. Everybody called me the serious girl. I didn't laugh very much. I laugh every day now. And you know what? I think one of the reasons my dad's doing so well is he laughs all day, every day, because he watches videos all day. He watches crazy videos. He watches all sorts of stuff. But in the end, he and my mom sit down and they watch animal videos. And I think that that's really, really healthy to laugh. All right. All righty then. Well, I now have a sore throat from talking so much. So that means it's about time for me to stop. Donna is from Gander, Newfoundland. Donna, oh, I saw the videos. I'm a huge fan of the group Great Big Sea, and they were based in Newfoundland, so I pay attention to that. The snow that they were showing pictures of this morning was amazing. Like you couldn't see the cars in the street. I hope you don't. I hope that the cleanup in the next couple of days is going to be a beast for you guys. Wow. I want to visit Newfoundland. I really do. Just not in the winter because I don't like cold weather. Watch Grace and Frankie. What was the new info? Justine, just watch the videos recorded. Watch the first hour, okay? All right. Let's see. Lucinda says, do you have any ideas for books that will help me deal? Hun, on endo, just go to the endometriosis website. They will give you the list of everything and a list of support groups. You'll be fine. They will help you, okay? You can feel free to call me this week if you need me to do that for you. If you don't have access to the internet, I will. Okay, my friends. What a good day. What a very, very good day. I wish you well. May you sleep well tonight and may you have a fabulous week this week. All right? Okay, I'll see you later. Goodbye, Facebook. All right, YouTube. All right, my YouTube friends, I will see you later.